Joint fluid characteristics. Hand and wrist pain, carpal tunnel syndrome. Symptoms are usually worse at night if diagnosis is uncertain or severe symptoms prompt consideration for surgery. It shows slowing of median nerve conduction at wrist. Carpal tunnel is made of carpal bones and transverse carpal ligament contain median nerve and tendons of flexor digitorum profundus, flexor digitorum superficialis and flexor pollicis longus. Electromyography is usually not done in case of CTS and rarely done to exclude other causes or in PTS with weakness or severe cases. Nocturnal wrist splinting holds the wrist in neutral position and prevents excessive flexion of hand during night. There is no text on this page. Dequervain tenosynovitis, most commonly occur in new mothers who hold their child with thumb outstretched, abducted/extended, caused by inflammation of abductor pollicis longus and extensor pollicis brevis tendons as they pass through fibrous sheath at radial styloid process, PE. Tenderness can be elicited by direct palpation of radial side of wrist at the base of the hand, Finkelstein test, passive stretching of affected tendons by grasping flexed thumb in palm with fingers rightward arrow. Illicit pain. Trigger thumb, pain over palmar aspect of first metacarpophalangeal and locking of thumb in flexion flexor carpi radialis tenosynovitis, pain with radial flexion of wrist and point tenderness of trapezium elbow pain radial tunnel syndrome, S/S, similar to lateral epicondylitis and may occur in conjunction with that condition. Tenderness over Lee extensor tendon WAD, examination, pain on flexing PT's long finger while PT actively extends fingers and wrists lateral epicondylitis, tennis elbow, caused by repetitive contraction of extensor muscles at lateral epicondyle in activities that require repetitive forceful wrist extension and supination, backhand in tennis add use of screwdriver, tenderness plus VE just distal to lateral epicondyle worsened by use, pain elicited by passive wrist flexion and resisted wrist extension and supination, pathophysiology, degeneration of tendon of extensor carpi radialis brevis near lateral epicondyle. Medial epicondylitis, golfer's elbow, tenderness over medial epicondyle, pain elicited by resisted wrist flexion and passive wrist extension. Panner's disease, osteochondrosis of capitellum, typically in adolescent who is actively involved in sports that involve throwing, common complaint, chronic dull pain, crepitation, and loss of supination and pronation. Shoulder pain. Common causes of shoulder pain. Rotator cuff impingement/tendinopathy, RCT, occurs due to repetitive activity above shoulders, common in middle, aged and older individuals. Pain then stiffness may show guarding with active movement but ROM otherwise is normal stiffness then pain, chronic tensile loading and compression by surrounding structures. Rightward arrow micro tears in rotator cuff tendons ESP. Supraspinatus rightward arrow fibrosis and inflammatory calcification. Pain may also originate from subacromial bursa or long head of biceps, other than rotator cuff tendons, flexion or abduction. Rightward arrow downward arrow space between humeral head and acromion. Rightward arrow pressure on supraspinatus tendon and subacromial bursa. Rightward arrow compression of these soft tissues. Rightward arrow impingement syndrome, Nair test, PT. Shoulder internally rotated and forearm pronated. Rightward arrow examiner stabilizes the scapula and flexes humerus. Rightward arrow reproduction of pain. Rightward arrow plus VE test, chronic untreated rotator cuff tendinopathy. Rightward arrow upward arrow risk of tear. Rightward arrow weakened abduction following a fall or minor trauma. Rotator cuff tear. Typically due to impingement of supraspinatus tendon, rotator cuff tendinopathy/tendinitis may present with pain but weakness will not be present in tendinitis without tear. Rotator cuff tear usually occurs after a fall on outstretched arm in patients 40. Pain at lateral shoulder limited, painful active abduction, external rotation, and raising arm above shoulder. Weakness but passive ROM is normal. X-ray may show calcific tendinitis but has low sensitivity. MRI. Visualize soft tissue around humeral head and most accurate to diagnose rotator cuff tear. Treatment of acute tear is surgery with best results obtained if performed within 6 weeks of injury. Adhesive capsulitis/frozen shoulder syndrome, markedly downward arrow ROM in multiple planes, glenohumeral joint loses its normal distensibility due to chronic inflammation, fibrosis, and contracture of joint capsule, causes, idiopathic secondary to underlying conditions like rotator cuff tendinopathy, most common, subacromial bursitis, paralytic stroke, DM or humeral head fracture, SX, gradual onset shoulder stiffness, with or without mild pain, that limits their ability to flex, abduct, e.g. reach overhead, or rotate the humerus, DX, confirmed on examination by 50% reduction in both passive and active RHEUM rupture of tendon of long head of biceps, associated with overuse ESP. In older patients, usually sudden onset pain, often with an audible pop and visible bulge, may report weakness but normal passive RHEUM posterior shoulder dislocation, causes, violent muscle contractions, as seen in a seizure or electrocution. Electrocution injury are a common cause of posterior shoulder dislocation. Presentation: the shoulder is typically held in adduction and internal rotation, with visible flattening of the anterior aspect of the shoulder and prominence of the coracoid process. Radiographs can reveal internal rotation of the humeral head with circular appearance, light bulb sign, widened joint space 6 mm, rim sign, or two parallel cortical bone lines on the medial aspect of the humeral head, trough line sign. Management: most are managed with closed reduction. Anterior shoulder dislocation, most common form of shoulder dislocation, usually caused by a direct blow or fall on an outstretched arm. Patient holds the arm slightly abducted and externally rotated. Foot pain: D/D of pain in forefoot, arthritis, bursitis, stress fracture, and Morton neuroma. Mulder sign: arthritis, typically in metatarsophalangeal joints not localized to single bony surface. Bursitis, caused by wearing poor fitted shoes for prolonged period. Rightward arrow: inflammation between metatarsal heads. Morton neuroma, pain between third and fourth toes on plantar surface. Mulder sign, clicking sensation and pain that occurs when palpating this space and squeezing metatarsal joints simultaneously, commonly occurs in runners. Not a true neuroma, but a mechanically induced neuropathic degeneration of interdigital nerves. Rightward arrow: numbness, pain, and burning in the distal forefoot from the metatarsal head to the third and fourth toes. Rightward arrow: worsened by walking on hard surfaces and wearing tight or high-heeled shoes. Diagnosis: primarily clinical. Treatment involves metatarsal support with a bar or padded shoe. Inserts to decrease pressure on metatarsal heads. Surgery is usually reserved for patients who fail conservative treatment. Plantar fasciitis, burning pain on plantar surface of foot that worsens with first step in the morning, gradually improves during the day but usually worsens by the end of the day due prolonged weight bearing, common in runners with repeated microtrauma who develop local point tenderness on plantar surface of foot. Examination: point tenderness at plantar surface of heel. Tarsal tunnel syndrome, compression of tibial nerve as it passes through ankle, caused by fracture of ankle bones. S/S, burning, numbness, aching of distal plantar, not dorsal, surface of foot/toes that sometimes radiate to calf. Tenosynovitis, inflammation of tendon and its synovial sheath, usually in hands and wrists. Due to overuse, following a bite or puncture wound, pain and tenderness along tendon sheath, particularly during flexion and extension. Knee pain. Bursitis, synovial sac alleviates friction at bony prominences and ligamentous attachments, vulnerable to acute injury, infections, crystalline arthropathy and autoimmune disorders like RA, SX. Pain and tenderness may be exquisite, swelling, erythema, PE, active RHEUM decreased or painful. Passive RHEUM normal as causes less pressure on inflamed bursa. Ans-Rhine bursitis/Pes anserinus pain syndrome, PAPS. Most PTS do not have true inflammation of bursa and pain may be contributed by multiple regional structures. Pes anserinus is formed by conjoined tendon of gracilis, sartorius, and semitendinosus. Ans-Rhine bursa is located anteromedially over tibial plateau, just below joint line of knee and deep to Pes anserinus. Causes: abnormal gait, trauma, or overuse, SX, localized medial knee pain and focal tenderness over anteromedial tibia, just below joint line. Exacerbated by pressure from opposite knee while lying on side. Valgus stress test does not exacerbate the pain. Rightward arrow I.E. Normal medial collateral ligament, DX, clinical grounds. Although X-ray can rule out concurrent osteoarthritis, doesn't cause locking and joint effusion Baker's cyst, due to excess fluid production by inflamed synovium in OA, RA, and cartilage tears. Rightward arrow excess fluid accumulates in popliteal bursa. Rightward arrow expands. Rightward arrow creates tender mass in popliteal fossa. Occasionally burst. Rightward arrow release contents into calf. Rightward arrow resembles DVT. Prepatellar bursitis / housemaid's knee, caused by chronic irritation of anterior knee in occupations requiring excessive kneeling, while other bursitis are usually non-infectious. Acute prepatellar bursitis is very commonly due to S. aureus infection from penetrating trauma, repetitive friction or extension from local cellulitis. Examination, pain with direct pressure and superficial cytic swelling over patella with variable signs of inflammation, DX, should be confirmed by aspiration of bursal fluid for cell count and gram stain, RX. Negative gram stain and culture, activity modification and NSAIDs. Positive gram stain and culture, treated with drainage and antibiotics. Differential diagnosis of anterior knee pain in young patients. Patellofemoral pain syndrome. Risk factors: overuse, most common, malalignment, e.g. angular deformities, weakness of hip abductors, and trauma, very common cause of chronic anterior knee pain in athletes and young women, worsened by prolonged sitting, due to flexion, or activity, climbing up or down stairs. May have crepitus with movement of patella. Presents with peripatellar pain, localized to patella. Diagnosis, challenging mainly on history and physical examination. Patellofemoral compression test, pain elicited by extending the knee while compressing patella into trochlear groove, and reproduction of pain with squatting are highly suggestive. No separation of tibial tuberosity on X-ray. X-ray and MRI usually do not show any abnormality and usually needed only when diagnosis is in doubt or PT do not improve as expected. RX, primarily mechanical exercises to stretch and strengthen thigh muscles / quadriceps, knee extensors, and hip abductors, and avoiding activities that aggravate pain. Reduced intensity of exercise ESP. Running. NSAIDs often prescribed but not helpful. Persistence is often required on part of PT as improvement may take weeks to months. Patellar tendinitis, overuse syndrome from repetitive jumping and kicking and in occupations with repetitive forceful knee extension. Presentation, episodic anterior knee pain after exercise. Unlike Osgood, PT has point tenderness over inferior pole of patella and patellar tendon. Osgood-Schlatter disease, common cause of knee pain typically in adolescent male athletes. Etiology, during early adolescence, 13 to 14 YRS in affected boys and 10 to 11 YRS in affected girls. Rightward arrow periods of rapid growth. Rightward arrow quadriceps puts traction apophysis of tibial tubercle where patellar tendon inserts. Rightward arrow sports like excessive running, jumping, kneeling. Rightward arrow traction apophysitis, Osgood-Schlatter dis. Rightward arrow worsened by activity and relieved by rest. B/L in 1/4 cases PE, edema and tenderness over tibial tubercle. Firm mass can sometimes be felt due to heterotopic bone formation. Pain reproducible by extending knee against resistance. Radiographic findings, non-specific, include anterior soft tissue swelling, lifting of tubercle from shaft, irregularity or fragmentation of tubercle. RX, activity restriction, stretching exercises, and NSAIDs. Tibial osteomyelitis, usually bacterial. PE, pain, swelling, tenderness, erythema, refusal to bear weight on affected extremity. Systemic SX may also be present. Pain does not remit with rest. Patellar fracture, caused by direct blow or a sudden force under load, e.g. fall from height, acute swelling, tenderness, and inability to extend knee patellar dislocation, occur after quick lateral movements around flexed knee, PE, flexed knee with patella displaced laterally. Patellar tendon rupture, rare. Although tears can occur with extreme loading in knee flexion, rightward arrow impaired knee extension septic arthritis, involve joint space proper and not anterior tissue, cause acute pain, joint effusion, and / fever, / chills and / leukocytosis. Pain on active and passive RHEUM. Onset occurs over days, and not hours like gout. More commonly due to Gram+VE rather than Gram, VE, and anaerobes. Fungal arthritis is usually due to Candida sp. Uncommon in non-immunocompromised PT. Less acute and dramatic and usually preceded by recent invasive Candida infection. Upward arrow risk in RA because of impaired phagocytosis and systemic immunosuppression. There is no text on this page. Blood cultures are +VE in 50% cases and should be drawn prior to antibiotics. Prompt therapy with 4 antibiotics and adequate joint drainage to prevent joint destruction. Iliotibial band syndrome, overuse injury, poorly localized pain at lateral knee, tenderness over lateral femoral condyle during flexion and extension, doesn't cause locking and joint effusion. Special tests for knee examination. Caused by forceful hyperextension of knee or a non-contact torsional injury during deceleration. Rapid onset hemarthrosis is typical, can occur in athletes due to rapid. There is no text on this page. Direction changes, subacute or chronic locking or popping sensation. Acute symptoms are usually mild effusions possible, but hemarthrosis is rare, or locking may also be palpable. Medial collateral ligament injury, caused by blow to lateral knee or forceful leg abduction and twisting / pivoting injuries. +VE medial knee tenderness and ecchymosis but absent catching during extension or rotation. Acute effusion / hemarthrosis usually absent unless ACL is also damaged. MRI is the most sensitive test but reserved for PTS, being considered for surgery. RX, mostly non-operative with RICE, rest, ice, compression, elevation, and analgesics with progressive return to activity as tolerated. Anterior cruciate ligament injury. Meniscal tear and NSAIDS symptoms lasting 3 to 4 weeks. Surgery reduce the risk of further joint injury. Medial meniscus tear more common than lateral, reduced extension, sensation of instability and knee effusion as meniscus is not directly perfused, hence, effusion is not apparent for several hours. X-ray. Older PT with tear due to joint degeneration will show signs of osteoarthritis, but normal X-ray in young adults with traumatic tear, DX, confirmed with MRI or arthroscopy. Hip pain, superior gluteal nerve. Rightward arrow innervates gluteus medius and minimus. Rightward arrow weakness can be due to neuromuscular disease, impingement / trauma of nerve, inflammatory myopathies. Rightward arrow positive Trendelenburg sign and gait. Avascular necrosis. Steroids. Rightward arrow effect on osteocytes. Rightward arrow trabecular thinning and collapse over months to years and abnormal lipid levels. Rightward arrow microembolus. Rightward arrow osteonecrosis. Progressive hip or thigh pain. Pain worse after activity but rest and night pain often present in advanced disease along with joint instability and downward arrow RHEUM. Normal physical findings and X-ray. Initially MRI visualize boundary between normal and ischemic bone, as well as zone of hypervascularity. Caused by occlusion of end arteries, micro-occlusion, supplying femoral head, abnormal endothelial function or upward arrow intra-osseous pressure. Rightward arrow necrosis and collapse of periarticular bone and cartilage. Femoral head is supplied by 2 main sources: ascending arteries and foveal artery, which lie within ligamentum teres. Foveal artery is patent in early life but may become obliterate later in life. Rightward arrow children less prone to avascular necrosis as compared to adults. Sickle cell disease. Rightward arrow occlusion of microcirculation in bone by sickling and upward arrow intraosseous pressure due to bone marrow hyperplasia. Rightward arrow osteonecrosis. X RHEUMATOLOGY equals subchondral lucency in advanced disease. Femoral head deformities also seen in advanced dystrocanteric bursitis. D/D of U/L hip pain in middle-aged patients include infection, arthritis, bursitis, trauma, and radiculopathy. Trochanteric bursitis is inflammation of bursa surrounding insertion of gluteus medius on greater trochanter of femur due to friction of tendons of gluteus medius and tensor fasciae lata over greater trochanter of femur. Causes: excessive frictional forces due to overuse, trauma, joint crystals or infection. S/S, hip pain when pressure is applied, sleeping on side, external rotation, or resisted abduction. Neuralgia paresthetica, due to compression of lateral femoral cutaneous nerve at waist. Rightward arrow burning pain and paresthesia at lateral thigh. Symptoms unaffected by motion. Back pain. Evaluation of back pain. Cauda equina, saddle anesthesia. Plus no response to previous therapy and plus VE neurological signs. Conservative therapy with NSAIDs better than with acetaminophen in PTS with no red flags. Mostly lower back pain is musculoskeletal in origin, but red flags suggest systemic disease, herniated disc, or bony abnormalities. E.G. lytic lesion or compression fractures may be present. MRI is done to look for disc disease, spinal infections, and cancers. Common cancers that metastasize to bone, breast, lungs, prostate, multiple myeloma, melanoma, renal and thyroid cancers. Causes of low back pain. Muscle strain pain can also radiate to buttocks and posterior thigh, but pain below knee is characteristic of herniated disc radiation below the knee. Cross straight leg raise test is also specific. Immune-mediated disorder affects ligamentous insertion site, enthesitis, gradual onset of LBP and progressive stiffness causes destruction of articular cartilage. ESP. Sacroiliac joint, sacroiliitis, and apophyseal joints of spine constant not relieved by rest. Generally occurs in PTS with recent overlying soft tissue infection or bacteremia. CRP and ES are usually upward arrow management of low back pain 4 to 6 weeks. Cervical spondylotic myelopathy, degenerative changes in cervical spine in older PTS, weakness, paresthesia, and loss of fine motor control. Acute equals 4 weeks. Most PTS will have resolution without additional treatment. Chronic equals 12 weeks and subacute equals 4 to 12 weeks tend to persist or recur. Exercise is the best treatment. Initially supervised, later transition to home exercise program. Neck and upper extremity symptoms are usually present and PTS will usually show signs of B/L upper motor neuron weakness, hyperreflexia, and upgoing plantar, and B/L sensory deficits. MRI is used for diagnosis. Cervical spondylosis affects 10% of people older than 50 years of age. H/O chronic neck pain is typical, limited neck rotation and the lateral bending due to osteoarthritis and secondly muscle spasm. Sensory deficit due to the osteophyte-induced radiculopathy and isolated SNIAS abnormalities are associated with good prognosis. Typical radiographic findings: bony spurs and sclerotic facet joints. Osteoarthritic changes are common in asymptomatic patients older than 50 years of age. Other findings may include narrowing of disc spaces and hypertrophic vertebral bodies. Vertebral osteomyelitis. Risk factors: for drug abusers, high index of suspicion, recent H/O distant site infection, sickle cell anemia and immunosuppressed PTS. Spine is a frequent site of osteomyelitic infection, causative organism, most commonly by S. aureus but also by Gram, VE organisms. SX, back pain not relieved by rest, fever is an inconsistent finding. PE, tenderness to gentle percussion over involved spinous process is most imp. Clue. Labs, leukocytosis is inconsistent, platelets upward arrow as a marker of inflammation/stress, ESR upward arrow usually 100 mm/HR, MRI is the most sensitive diagnostic study, RX, long term for antibiotics with or W/O surgery. Lumbosacral strain, most common cause of back pain. Lifetime risk 80%, S/S, acute onset back pain after physical exertion, no radiation, no neurologic deficits, PE, local tenderness and contraction of paraspinal muscles. Normal neurologic exam and straight leg raise test, RX, NSAIDs and early mobilization, prevention, proper patient education is important. The education should emphasize the importance of strengthening the supporting muscles, including abdominal muscles, by regular exercise, choosing an appropriate sleeping posture, e.g. avoiding sleeping on the stomach, and learning proper techniques for bending and lifting objects. Exercises with repetitive twisting and bending should be avoided. It is important to bend at the knees, not at the waist. While lifting an object, one should also bend the knees, keeping the back straight. This technique is very useful in preventing strains and back injuries. Warm-up exercises should be done before any sporting activities. Lumbar disc herniation, acute back pain with/without radiation to unilateral lower leg usually, sciatica, recall inciting event, aggravated by activity and lumbar flexion, relieved by rest, spine not tender to palpation, RX, mostly spontaneous resolution of symptoms. Rightward arrow initial management focused on acute relief of symptoms. Nonsteroidal anti-inflammatory drugs and acetaminophen are the preferred first-line drugs. Short-term use of opioids or muscle relaxants can be considered in patients with persistent pain but is associated with significant sedation. Activity modification is often advisable, but patients should be encouraged to maintain moderate physical activity. Lumbar spinal stenosis. Narrowing of spinal canal with compression of one or more spinal nerve roots, not spinal cord compression. Due to narrowing of intraspinal, central, canal, lateral recess, or neural foramen, primarily seen in degenerative arthritis with osteophyte formation affecting the facet joints, spondylosis. Other factors: hypertrophy of ligamentum flavum, bulging of intervertebral disc, degenerative disc disease and spondylolisthesis, displacement of one vertebral body relative to another, mostly in PT60-YO, S/S, SX are posture dependent. Back pain radiating to buttocks and thigh. Extension of lumbar spine, e.g. standing and walking upright, further narrows spinal canal and worsens symptoms and relieved by lumbar flexion, walking uphill and leaning on a cane. Onset of pain with walking is referred to as neurogenic claudication. Claudication, as it may resemble vascular claudication, pain with walking and relieved by rest. Neurogenic claudication relieved by walking while leaning forward, shopping cart sign, and exercise with spine flexed, e.g. cycling, does not incite symptoms, may be associated with numbness and paresthesia, DX, confirmed by MRI, RX, mostly conservative with physical therapy and exercise, some may require surgical intervention. Neurogenic vs. vascular claudication. Impingement of lumbar nerve roots, can cause pain at posterior hip, thigh and lower leg. Hip mobility is normal but may have exacerbation of pain on hip flexion and knee extension, straight leg raise. Vertebral compression fracture. Most common cause of traumatic VCF can develop acute compression fracture with H/O minimal trauma like coughing, bending, lifting. Each VCF lead to /= 1 cm decrease in height. Neurological examination is typically normal. Loss of DTRs is common in elderly ESP. Above 70 YRS and not related to VCT. Seronegative spondyloarthropathies, ankylosing spondylitis. Spinal rigidity, upward arrow, the risk of vertebral fracture with minimal trauma. Additional findings: thoracic wedging and hyperkyphosis. Anterior uveitis, iritis, is the most common extra-articular manifestation, 25 to 40% cases. Rightward arrow, inflammation of uveal tract, iris, ciliary body, and choroid. Rightward arrow, intense pain and photophobia in one eye. Osteopenia/osteoporosis. Rightward arrow, upward arrow, osteoclast activity in the setting of chronic inflammation, mediated by TNF, ANIL, 6, due to scarring of valve cusps. Enthesitis. X-ray showing sacroiliitis can confirm the diagnosis may be, VE early rightward arrow MRI can confirm in such cases rightward arrow fusion of vertebral bodies with ossification of intervertebral discs, bamboo spine, also confirm the diagnosis, inflammation and pain at the site where tendons and ligaments attach to bone, commonly due to tendon or ligament stress rightward arrow manifest as acute swelling and pain, PE, tenderness at the site of tendon insertion, insertion of Achilles tendon at heel is the most common site of presentation rightward arrow worsens with activity, lower back pain improves with activity, can involve costosternal junction, shoulders, elbows, hips, iliac crest. Tibial tuberosity and other sites, chronic rightward arrow fibrosis and calcification, can be isolated like plantar fasciitis but characteristic finding in spondyloarthropathies such as ankylosing spondylitis, most common, psoriatic arthritis, reactive arthritis can be present at multiple sites. Psoriatic arthritis. I.E. Separation of nail bed I.E. White plagues with silvery scale, morning stiffness is present as in most inflammatory arthritides. Sausage digit rightward arrow diffusely swollen finger, RX, options include, NSAIDs, methotrexate and anti-TNF agents reactive arthritis, type of seronegative spondyloarthropathy. Usually result from enteric or genitourinary infection by Shigella, Salmonella, Yersinia, Campylobacter, or C. difficile, triad of non-gonococcal urethritis, asymmetrical oligoarthritis, and conjunctivitis. Often involves knee and sacroiliac spine. In addition to the classic triad, mucocutaneous lesions and enthesitis, Achilles tendon pain, are common findings. Malaise and characteristic cutaneous findings, keratoderma blenuragica and balanitis circinata, are also present. Not all symptoms always present rightward arrow high suspicion for reactive arthritis in case of any asymmetrical oligoarthritis associated with the urethritis, conjunctivitis, or mouth ulcers, synovial fluid analysis usually sterile, RX, NSAIDs are first line during acute attack. Enteropathic arthritis, in 10 to 20% PTS with UC and Crohn disease, lower extremities and sacroiliac joints are mainly involved. Symptoms wax and wane with symptoms of bowel disease. These PTS have prominent GI symptoms and other extraintestinal manifestations. ANCA may be present in UC and ankylosing spondylitis despite the absence of vasculitis. Rheumatoid arthritis. Peak incidence at 50 to 75 yo, reduced grip strength can occur occasionally and is a sensitive sign of early disease. Osteoporosis, upward arrow pro-inflammatory cytokines, corticosteroid therapy, and lack of physical activity rightward arrow local, around inflamed joint, and generalized loss of bone mass, upward arrow risk of osteopenia, osteoporosis, and bone fractures ESP. If other risk factors, e.g. low body weight, female sex, smoking, family history of osteoporosis, postmenopausal state, excessive alcohol intake, other comorbidities, are present degree of bone loss correlates with disease activity, strategies to prevent bone loss, adequate physical activity, optimization of vitamin D and calcium intake, minimization of glucocorticoid dose, low threshold for starting bisphosphonates in RAPTS. X-ray of long-standing, poorly controlled disease, periarticular osteoporosis. Osteoporosis, joint erosions, and joint space narrowing, episcleritis inflammation seen on white of the eye without involvement of uveal tract most strongly associated with RA and IBD, treatment. Start DMARDs ASAP as joint damage begins early in the course. Methotrexate is preferred initial DMARD in moderate to severe RA due to efficacy and long-term safety profile test for TB, HBV, and HCV before starting. Contraindications of methotrexate, pregnant PT and those planning to become pregnant in near future, severe renal insufficiency, liver disease, or excessive alcohol intake NSAIDs and COX, 2 inhibitors adjunctive therapies for symptomatic relief but do not reduce progression. Glucocorticoids can relieve symptoms and short-term radiographic progression not effective in preventing eventual joint destruction. Felty syndrome. Felty syndrome is a clinical disorder seen in patients with severe, long-standing, 10 years, RA but rarely precedes the diagnosis. Characterized by neutropenia and splenomegaly. Splenomegaly without neutropenia can also occur in patients with RA, but the diagnosis of Felty syndrome should not be made in the absence of neutropenia. PTS with FS have severe seropositive RA with upward arrow risk of extra-articular manifestations, more common in women. Peak incidence in 4th and 5th decade, pathophysiology unknown, associated with HLA, DR4 upward arrow incidence in PTS with FH of RA suggesting genetic component. FS usually improves with treatment of underlying RA, e.g. methotrexate. Osteoarthritis. Diabetes. Prolonged rest may cause stiffness and pain but usually worse with activity. Diagnosis is usually clinical. X-ray confirms the diagnosis. Arthrocentesis is sometimes performed. Show clear fluid without inflammatory cells. Hip osteoarthritis, pain in groin, buttock, or pelvis and can radiate to lower thigh or knee. Downward arrow external and internal rotation but synovitis, redness, warmth, and tenderness, absent. There is no text on this page. NSAIDs relieve pain but do not alter progression of disease. Systemic lupus erythematosus, SLE. Young African American, Hispanic and Asian women are at greatest risk. Hematologic manifestations of SLE. Polyarticular knees, carpal bones and joints of fingers most commonly involve joint pain often exceeds objective findings. X-rays show no evidence of joint destruction/erosion can also cause stroke. There is no text on this page. Headache, due to vasculitis, and upward arrow immune complexes. GI blood loss. E.g. Peptic ulcer formation due to chronic NSAIDs use. SLE can cause pancytopenia due to concurrent immune-mediated destruction of all 3 cell lines. Bone marrow suppression can also cause pancytopenia. However, this is not usually due to SLE but rather from other coincidental conditions like leukemia, drugs, myelodysplasia and malignant invasion of bone marrow. As a result, bone marrow biopsy is frequently done in SLE-PTS to exclude other causes. Renal manifestations of SLE, immune complexes composed of DS, DNA and anti-DS, DNA antibodies deposit in mesangium and/or subendothelial space. Rightward arrow intense inflammatory response and complement activation. Rightward arrow lower C3 and C4 levels and nephritic syndrome. Immune complexes may also deposit in subepithelial space. Rightward arrow membranous glomerulonephritis. Rightward arrow nephrotic syndrome without hypocomplementemia. Clinical features: fatigue, painless oral ulcers, non-deforming arthritis, renal abnormalities, hematuria, proteinuria, glomerulonephritis, cytopenias. Most common manifestations of active disease: morning stiffness much shorter than RA. Initial screening. 1. Initial evaluation in PT. Suspected of SLE should include blood counts to look for cytopenias, urine analysis, and creatinine to screen for nephropathy. 2. ANA titers obtained early sensitive but not specific. Rightward arrow if positive. Rightward arrow confirm with more specific AB like anti-dsDNA and anti-SMITH-AB. Many PTS will be negative for these even in presence of multi-system involvement. 3. Complement level, ESR, and CRP should be assayed to assess ongoing disease activity. Monitoring disease activity in SLE, periodic blood counts, inflammatory markers, e.g. ESR, complement levels, and anti-dsDNA titers, regularly screen for lupus nephritis with urinalysis, serum creatinine, and urine protein assay. Treatment, choice of drug depends on degree of organ involvement. Most PTS with active SLE benefit from hydroxychloroquine, a safe and well Tolerated medicine. Rightward arrow can cause retinal toxicity, rarely leading to irreversible vision loss. Rightward arrow common after 5 to 7 years of therapy. Rightward arrow perform baseline ophthalmologic evaluation, with annual reassessment starting after 5 years. Cyclophosphamide is reserved for PTS with significant renal or CNS involvement. Rightward arrow can cause acute hemorrhagic cystitis, bladder cancer, sterility, and myelosuppression. Acrolein is the bladder toxic metabolite. Rightward arrow. Drink plenty of water, void frequently, and take mesna to prevent renal complications. Anti-phospholipid syndrome, APS. Thrombocytopenia. It prolongs PTT in vitro as it binds to phospholipids used in most assays. Artifact and does not correlate with bleeding in vivo. Indirect indicator of LA. Specific tests: diluted Russell Viper venom test and kaolin clotting time. Some healthy PTS may transiently become positive for APS antibodies, so all PTS positive for these antibodies should have a repeat test for antibodies after 12 weeks to confirm diagnosis. Biggest risk factor for APS, SLE, in 40% cases of SLE, but can occur independently as well. The APS associated autoantibodies mediate a hypercoagulable state that may cause placental thrombosis. Potential complications include recurrent first trimester miscarriage, fetal demise, preeclampsia, and fetal growth restriction. RX. Patients with APS require anticoagulation with low molecular weight heparin, LMWH, and low-dose aspirin after acute thrombotic events or to prevent pregnancy loss or venous thromboembolism during pregnancy. Patients require long-term treatment with warfarin. Add hydroxychloroquine in PT with concomitant SLE. False positive RPR/VDRL is common in APS as syphilis antigen used in RPR contains cardiolipin. DMARD's classification: non-biologic agents, small molecule drugs produced by conventional chemical synthesis. Rightward arrow target inflammatory pathways, e.g. sulfasalazine, hydroxychloroquine, methotrexate, leflunomide, azathioprine. Biologic. Large molecule agents produced by biologic means, primarily recombinant DNA technology. Rightward arrow target cytokines and cell surface proteins, e.g. TNF inhibitors, etanercept, infliximab, adalimumab, tocilizumab, rituximab. Oral ulcers, ANIT, cytokines agents in moderate to severe SLE and RA. Steroid-sparing agent LFTs are monitored frequently. Other SE, alopecia, pulmonary toxicity, bone marrow suppression. Folic acid supplementation. Rightward arrow downward arrow SE. SE reversible usually on discontinuation, but watch carefully for flare-up neutropenia, infections, reactivation of latent TB, opportunistic infections. Raynaud's phenomenon. For example, systemic lupus erythematosus, scleroderma, thromboangiitis obliterans, dilated or dropout vessels in nail fold capillaries predictive of future development or presence of CT disease. Dihydropyridine CCB like amlodipine and nifedipine are used. Primary RP, upward arrow vascular response to cold and emotional stress. Symmetrical, episodic attacks. Episodes may involve tingling, numbness, pain with color changes of pallor, white attack, or cyanosis, blue attack. Treatment: smoking, cessation and avoidance of cold temperatures and emotional stress. Pharmacologic therapy includes dihydropyridine calcium channel blockers like nifedipine or amlodipine. Secondary RP, based on history and physical examination, workup for the patient with suspected secondary Raynaud's phenomenon may include CBC and metabolic panel, urine analysis, antinuclear antibody and rheumatoid factor ESR and complement levels, C3 and C4. If ANA is positive, specific antibodies may be obtained. Systemic sclerosis, SSC. Classic early skin manifestations: thickening or hardening, edema and pruritus. Primarily affects esophagus. Rightward arrow smooth muscle atrophy and fibrosis in lower esophagus. Rightward arrow choking, hoarseness. esophageal monometry, hypomotility, and incompetence in lapalm. Complications are the most common cause of death in SSC. In 40% cases of diffuse SSC, most common palm complication. In 15% cases of limited SSC, right heart failure. Before the advent of ACEI, renal crisis leading to HTN was the most common cause of death. SSC extreme heterogeneity in manifestations and severity, some degree of skin involvement in seen in almost all cases. Limited SSC, sclerosis limited to skin of wrists, hand, and face, may have esophageal dysmotility and vascular symptoms, e.g. Raynaud phenomenon, but extradermal manifestations are limited in most cases. Diffuse cutaneous SSC, with dermal thickening involving proximal extremities or trunk, more likely to cause extradermal manifestations and carries a more severe prognosis. Antibodies, ANA in all patients, anti-topoisomerase I antibodies in diffuse. Anticentromere in limited Sjogren's syndrome, more in females in 5th or 6th decade of life. Plus dyspareunia, enlargement and firmness to palpation of these glands. Extraglandular manifestations may include arthritis, LAD, Raynaud phenomenon, or vasculitis. Occasionally optic neuritis may be present. Other antibodies that may be present, ANA, RF, DX, confirmed by subjective and objective evidence of dry mouth and eyes in the presence of either histologic presence of lymphocytic infiltration of salivary glands or serum autoantibodies directed against SSA, RHO, and/or SSB, LA. Paraneoplastic syndrome. Muscle weakness and DTRS improve with repetitive isometric contraction. Paraneoplastic syndromes are common in cancers of lungs, ovaries, breast, and lymphomas. Differential diagnosis of myopathy. Glucocorticoid-induced myopathy, acute myopathy associated with high-dose glucocorticoid in critically ill PTS is less common than chronic myopathy, upward arrow muscle catabolism and downward arrow anabolism as a direct effect of glucocorticoids. This risk of GIM rises with higher doses of glucocorticoids, generally 40 mg hydrocortisone daily or its equivalent. Muscle power upward arrow after discontinuation, but recovery takes weeks to months. Fibromyalgia/polymyositis/PMR. And greater trochanter fibromyalgia, DX, history and exam findings. Revised 2010 American College of Rheumatology criteria suggest using widespread pain index and symptom severity score rather than trigger points for diagnosis of fibromyalgia. Rightward arrow better address cognitive problems, fatigue, and severity of symptoms. There is no text on this page. Diagnosis depends on tenderness in at least 11 of 18 defined trigger sites. RX, initial fibromyalgia treatment. Emphasize patient education. I.E. Fibromyalgia is a benign condition with a favorable prognosis, regular aerobic exercise and good sleep hygiene. PTS perceive that their pain and fatigue worsen acutely during or after exercise. E.G. Aerobic exercise, strength training, stretching. Gradual and incremental low-impact exercises, e.g. swimming, fast walking, and water aerobics, improve pain and fatigue and improve long-term benefits. Water exercises can greatly reduce pain. Patients who do not respond to conservative measures may require medications. Tricyclic antidepressants, for example amitriptyline, are preferred first-line drugs. Serotonin and norepinephrine reuptake inhibitors, e.g. duloxetine, milnacipran, and pregabalin, are alternate therapies that may be useful for the patients who do not respond to tricyclic antidepressants. Patients with persistent symptoms may require combination drug therapy, referral for supervised rehabilitation, pain management consultation, or cognitive behavioral therapy. Polymyositis. Chronic disease require long-term treatment. Rightward arrow high-dose steroids are needed for remission. Invariably elevated definitive diagnosis. Mononuclear infiltrate surrounding necrotic and regenerating muscle fiber. Careful examination and age-appropriate screening is needed. inflammatory disease of muscle, slowly progressive proximal muscle weakness of lower extremity, difficulty negotiating stairs or rising from seated position. Proximal arm weakness follows rightward arrow, difficulty working with arms overhead. May develop dysphagia due to involvement of striated muscles of upper pharynx. Mild pain or tenderness may be present, but severe pain or lack of muscle weakness should prompt other diagnosis. Electromyography is used for differentiating polymyositis from other causes of weakness but is non-specific dermatomyositis. Dermatomyositis 6 times more common in females. Anti-Jo1 rightward arrow anti-synthetase antibody, anti-Me2 rightward arrow antibody against helicase, classically proximal extensor muscle inflammatory myopathy, Gottron's papules, pathognomonic eruption on chest and lateral neck known as Schall sign, usually 10 times the upper limit, can lead to myoglobin-induced acute kidney injury by causing damage to tubular cells. Regular, appropriate screening is essential. 15% will have or will develop internal malignancy, most commonly ovarian, pancreatic, lungs, stomach or colorectal cancers, and non-Hodgkin lymphoma, polymyalgia rheumatica. Rapid and thorough relief is expected. Rightward arrow failure to improve rightward arrow diagnosis in question. Physical examination is frequently unremarkable, with patients having no focal tenderness or pain with active or passive ROM. PTS have objectively normal muscle strength, VE signs of inflammation. When asked to identify location of pain, patients typically indicate soft tissues and not the joints. Charcot joints, osteophyte, and loss of cartilage. Pathogenesis, loss of neurologic input, loss of pain, temp, proprioception, rightward arrow repetitive trauma of weight-bearing joints. Rightward arrow 2 degenerative joint disease, joint deformation and functional limitation. Rightward arrow X, ray, loose bodies, osteophytes, and loss of cartilage. In diabetes, vasculopathy also contribute to disease. Gout, hematologic malignancies and psoriasis. Medications that raise E.G thiazide diuretics, cyclosporin, or lower E.G allopurinol, medication levels, acute flares, abrupt onset with maximal symptoms in 12 to 24 hours. Rightward arrow if gradual onset in more time than joint aspiration for cell count, gram stain and culture done to check for septic arthritis. Otherwise typical gout flare typically treated. Presence of crystals will not rule out septic arthritis, as these will be present between attacks. In septic arthritis, cell count 50,000/mm3, gram stain plus rightward arrow start empiric antibiotic until culture results are known. Up to 50,000 cells/mm3 negatively birefringent needle-shaped crystals, X-ray in chronic gout, punched out erosions with an overhanging rim of cortical bone known as a rat bite lesion. Urate lowering medications are not given after first attack, given in recurrent attacks and complicated disease. TOFI, renal uric acid stones. Allopurinol inhibits uric acid production and used to prevent gout attacks in PTS with hyperuricemia due to PV, NSAIDs, glucocorticoids, or colchicine given in acute attack. Short-term glucocorticoids are also given in PTS, starting on urate lowering meds to prevent flare. Steroids are relatively CI in DM. Avoid food containing fructose and other refined sugars. Ethanol, upward arrow uric acid production and downward arrow clearance. Obesity, HTN, aspirin, beta blockers, diuretics, and DM are risk factors for recurrence of gout. Smoking and upward arrow coffee intake. Downward arrow risk of gout. Pseudo-gout, age 65 years. Can affect knees, ankles, upper extremity, large joints, and may involve multiple joints concurrently. Hard to detect but diagnostic. Common in hyperparathyroidism with chronic hypercalcemia, hypothyroidism, and hemochromatosis. Pseudo-gout. Rightward arrow look for these causes. Acute attacks occur in the setting of trauma/overuse, surgery, or medical illness. Can also cause chronic inflammatory arthritis resembling rheumatoid arthritis and non-inflammatory degenerative arthritis resembling osteoarthritis. X, RHEUMATOLOGY is also useful for diagnosis rightward arrow chondrocalcinosis, indicator of CPPD, calcium pyrophosphate dehydrate crystal deposition disease. Hereditary hemochromatosis type 2 DM and not type 1. DX, serum iron studies rightward arrow confirm with genetic testing, liver biopsy generally not done but can be done to stage liver disease or confirm diagnosis if iron studies are suggestive and genetics not positive. RX, serial phlebotomy to deplete serum iron stores. Secondary amyloidosis. Autoimmune hepatitis, smooth muscle antibodies, variety of liver diseases asymptomatic mildly elevated aminotransferases, acute liver failure and cirrhosis, associated with type 1 DM and not type 2. Joint complications are less common and cause arthralgia of small joints. Whipple disease, multi-system disease characterized by a multitude of possible manifestations. S/S, history of chronic malabsorptive diarrhea, steatorrhea, flatulence, abdominal distension, protein-losing enteropathy, weight loss, migratory non-deforming arthritis, lymphadenopathy, and a low-grade fever. Can cause damage to the eye, CNS, and myocardium. Caused by infection with gram-positive Bacillus Trophirema whipplei. Unknown mechanism of transmission, DX, small intestinal biopsy and PCR in patient with clinical symptoms consistent with the disease. Biopsy rightward arrow PA plus VE macrophages in the lamina propria containing non-acid, fast gram-positive bacillus. Paget's disease of bone. Frontal bossing. Bossing, cranial nerve dysfunction also affects pelvis and clavicle. Serum calcium normal in the absence of other risk factors like prolonged immobility and hyperparathyroidism, but urine calcium may be upward arrow. Cortical thickening radionuclide bone scan is used to fully stage the disease, inhibit osteoclast function and decrease bone turnover. Alkaline phosphatase, ubiquitous enzyme highest expression in bone and hepatobiliary tissue. Useful marker of cholestatic liver disease, not hepatocellular, in which there is elevation of transaminases, and diseases of bone causing increased bone turnover. Most common cause of isolated, asymptomatic elevation of alkaline phosphatase in an elderly patient is Paget disease of bone, osteitis deformans, most commonly incidentally discovered on routine blood test. An alkaline phosphatase level can be strikingly elevated, often 10 times upper limit of normal. Fractionation of alkaline phosphatase rightward arrow predominance of bone rather than liver isoenzymes, asymptomatic PTS with minimal disease activity, incidental discovery of mildly upward arrow alkaline phosphatase, may be left untreated and observed. Symptomatic PTS and those with high risk bone involvement, like skull and weight-bearing long bones, should be treated to downward arrow pain and risk of complications. Osteitis fibrosis cystica, von Recklinghausen disease of bone, presents with bony pain, is characterized by excessive osteoclastic resorption of bone, leading to replacement with fibrous tissue, brown tumors. Very rare, seen primarily in patients with parathyroid carcinoma. It can also occur in primary and secondary/tertiary, advanced renal disease, hyperparathyroidism. Infectious arthritis, viral arthritis, can present similar to RA. RF, plus VE in RA, viral and bacterial arthritis, and also in normal individuals, and ANA, sensitive for SLE, but may be positive in RA. HIV, hepatitis, and normal individuals, may also be positive. Symmetric inflammatory arthritis that resolves in 2MO is viral arthritis, causative organisms, parvovirus, hepatitis, HIV, mumps, and rubella. Among many others, RX, NSAIDs for resolution of symptoms. Lyme disease. Most prevalent in northeastern and upper mid-western states of U.S. Osteomyelitis, fever, malaise, localized joint pain and swelling can be monoarticular and oligoarticular. Knee is most commonly involved. Joint synovial fluid shows inflammatory profile. Rightward arrow AV. Leukocyte count 25,000 cells/ul. Diagnosis of Lyme arthritis confirmed by ELISA and Western blot rightward arrow RX, oral doxycycline or amoxicillin in the absence of other manifestations of Lyme dis. Chronic osteomyelitis, central lytic bone defect with surrounding sclerosis termed as Brodie's abscess. Gonococcal arthritis. Nucleic acid amplification test or cefotac-SIM. Septic arthritis in sexually active young adult is gonococcal arthritis until proven otherwise. Gram stain of synovial fluid, plus VE in 25% cases, blood cultures, positive in 20 to 50% cases, and genital/pharyngeal NAAT, plus VE in 90% cases, rightward arrow used to confirm diagnosis. Arteritis, giant cell arteritis. Aortic aneurysm can happen in PPL with GCA. UW, 4,460 diminished pulses and / or brutes over axillary, brachial, or femoral arteries and over supraclavicular and / or carotid areas, followed by serial chest X-rays, fundoscopy, swollen and pale disc with blurred margins with a slow taper over several months. Takayasu arteritis. Mononuclear infiltrates and granulomatous inflammation of vascular media, rightward arrow arterial wall thickening with aneurysmal dilation or narrowing and occlusion, initially non-specific symptoms, later arterio-occlusive symptoms develop. PTS commonly have anemia. Vascular tumors, glomus tumors, common benign vascular tumor, triad of severe intermittent pain, tenderness, and sensitivity to touch, subungual in 70% cases, other sites palm and wrist, common in fourth decade. Females, males. Bone tumors. Osteoid osteoma, benign bone-forming tumor, common in adolescence and early adulthood. ESP. Males, most commonly affects proximal femur, may also involve other long bones and spine. SX, increasing pain that worsens at night. No association with physical activity. Pain relieved by NSAIDs and strongly suggests diagnosis. PE, children, focal tenderness, swelling or deformities. PE, adolescents, often no focal findings on exam. X-ray, typical small, round, lucency with sclerotic margins and sometimes central ossification. RX, NSAIDs for symptomatic relief and serial examination and X-ray. Every 4 to 5 months to monitor lesion. Surgical resection reserved for those with refractory symptoms. Most lesions resolve spontaneously over several years. Osteosarcoma, most common primary tumor affecting children and young adults. Boys B/W 13 to 16 yo are at higher risk. Location, frequently occur at metaphysis of long bones such as distal femur, proximal tibia and proximal humerus. S/S, chronic localized pain. Constitutional SX like weight loss, fever, and malaise usually absent. PE, palpable tender soft tissue mass. X-ray, destruction of normal bone pattern with indistinct margins. And a mixture of radiothense and radiolucent areas. Characteristic spiculated sunburst pattern and periosteel elevation known as Codman triangle. Labs, upward arrow alkaline phosphatase and lactate dehydrogenase from turnover of damaged osteocytes. High levels equals worse prognosis. Upward arrow ESR non-specific marker of inflammation. RX, tumor excision and chemotherapy. Ewing sarcoma, highly malignant early metastasis to lungs and lymph nodes, affects long bones of extremities. Lower limb, upper limb. Most commonly metaphysis and diaphysis of femur, followed by tibia and humerus. Usually in white males in first/second decade of life. Adolescent males, rare, but second most common primary bone tumor. S/S, pain and swelling for many weeks/months, deformity, erythema, and warmth of local areas sometimes seen. Rightward arrow misdiagnosed initially as osteomyelitis because of intermittent fever, leukocytosis, anemia, and upward arrow ESR. Cause extensive involvement of affected bone. Systemic symptoms in 20% PTS, may demonstrate multiple layers of new subperiosteal bone formation. Radiographs, lamellated appearance or onion skin periosteel reaction usually lytic, central, and accompanied by endosteel scalloping rightward arrow followed with moth-eaten or mottled appearance and extension into soft tissue. RX, radiation, surgery, and multi-drug chemotherapy. Radiation and chemotherapy used preoperatively chondrosarcoma occur in 5th or 6th decade of life. People with multiple endochondromas and hemangiomas are at higher risk than general population. X-ray rightward arrow fusiform defect with scalloping fibrosarcoma, malignant spindle cell neoplasm in 30-60 Yo. Clinical picture, painful mass. X-ray, osteolytic lesion whose margins are well defined or ragged and moth-eaten giant cell tumor of bone, benign and locally aggressive seen in young adults. S/S, pain, swelling, downward arrow ROM around affected joint. 10 to 35% experience pathologic fractures due to thinning of bone cortex in weight-bearing areas. X-ray, typically present on X-ray of epiphyseal region of long bone, most commonly distal femur and proximal tibia. Show expansal and eccentric lytic areas. MRI, show both hemorrhagic and cystic regions. Pathology, sheets of interspersed large osteoclast giant cells that appear as round to oval polygonal or elongated mononuclear cells. Treatment, surgery, e.g. intralesional curettage with or without bone grafting. First line of GCTB screening studies osteoporosis. Modifiable risk factors. Hormonal factors like low estrogen, malnutrition, downward arrow calcium, downward arrow vitamin D, meds like glucocorticoids or anticonvulsants, immobility, weight-bearing exercise is preventive, cigarette smoking, excess alcohol intake, dose-dependent upward arrow in risk of osteoporotic fracture, significantly upward arrow risk if 2 drinks/day, strict vegan vegetarian diet, as it does not contain calcium in contrast to lacto-ovo-vegetarian diet includes foods fortified with calcium such as dairy products, orange juice, cereals, and whole grains. Non-modifiable risk factors. Female gender, advanced age, small body size, late menarche or early menopause, Caucasian/Asian ethnicity. FH of osteoporosis. One-time DEXA screening for osteoporosis in all women/equals 65 Yo and younger points who have other risk factors for osteoporosis. Most significant risk factor in U.S. is post-menopausal state. Interpretation of DEXA scan of hip and spine, 2.5 SD below mean, i.e. T-score, 2.5, for a young adult at peak bone density. Rightward arrow significant fragility and risk of fracture, 1 to 2.5 SD below mean, i.e. T-score, 1 to 2.5, rightward arrow osteopenia. Rules for follow-up DEXA and screening are not well established. Pap smear, downward arrow. The risk of cervical cancer in young and middle-aged women, risk of cervical cancer, downward arrow with age. Women 65 or those who have cervix removed for reason other than cancer, rightward arrow. No need of further pap smear. Colonoscopy, start at 50 in ppl with normal risk and repeated every 10 years unless there is evidence of polyp. PT with high risk polyp. Rightward arrow follow up colonoscopies every 3-5 years. CT chest, X-ray does not. Downward arrow mortality in PTS with high risk of lung cancer. Low-dose CT has shown to downward arrow lung cancer related mortality in high risk PTS. Medicine, cisplatin, carboplatin. Pharmacology uses treat ovarian, testicular, bladder cancer. Side effects: cochlear dysfunction, aminoglycoside, cyclophosphamide, hydroxychloroquine, ethambutol, phenytoin, isoniazid, vincristine, heavy metals, chronic alcoholism, beta blockers, ergotamine, amiodarone, lithium cyclosporin. Cochlear dysfunction, acute hemorrhagic cystitis, bladder cancer, sterility, myelosuppression, optic neuritis, peripheral neuropathy, digital vasospasm, Raynaud's, thyroid dysfunction, gout. Contents: radial head subluxation, nursemaid's elbow. 2 supracondylar fracture of humerus. 2 growing pains. 3 clubfoot/talipes, equinovarus. Equinovarus. 3 metatarsus adduction. 3 slipped capital femoral epiphysis. 4 leg cab Perthes disease. 5 hip dysplasia. 6. Developmental dysplasia of hip. 6 femoral neck stress fracture. 9 transient synovitis. 9 pauci, arthritis. 9 rickets. 10 osteogenesis imperfecta. 10 Kawasaki disease. 10 acquired torticollis. 12 atlantoaxial instability in Down syndrome patients. 12 spondylolisthesis. 12 lytic bone lesions in children. 12 Langerhans cell histiocytosis. 13 pointers. 13. Rheumatology/orthopedics and sports, PIDS radial head subluxation, nursemaid's elbow. Common in 1 to 5-year children, response to treatment is also diagnostic. Attempted forearm supination rightward arrow child will resist and cry out in pain but otherwise usually not in distress also commonly performed but may be less successful and more painful pop may be heard on successful reduction, no post, reduction films are needed when patient resumes full use of extremity supracondylar fracture of humerus, elbow fractures almost 50% fractures of children, most common type is supracondylar fracture of humerus, commonly in ages 2 to 12 years, after a fall on outstretched arm with elbow extended. X-ray usually show large triangular anterior fat pad, lucency, and posterior fat pad, lucency. May be complicated by neurovascular injury or compartment syndrome. Neurovascular injury rightward arrow frequently monitor pulses, compartment syndrome rightward arrow progressively increasing pain ESP. With increasing swelling rightward arrow remove any bandage, measure compartment pressure and emergent orthopedic evaluation for possible fasciotomy. Growing pains. Growing pains are a common musculoskeletal complaint in children, occurring in approximately 10% to 30% of children aged 2 to 12 years. Unknown etiology, but they are unrelated to growth despite their name. Diagnosis clinically made in the absence of the systemic symptoms and abnormal examination findings. Laboratory studies and radiographs not necessary. Followed closely to monitor for pain that increases in frequency or intensity, which may warrant further evaluation. Children with growing pains often have a lower pain threshold and more depressive symptoms when compared to other children, but psychiatric evaluation is not required for these patients. Clubfoot/Telepes equinovarus definition, equinus and varus of calcaneum and talus, varus of midfoot and adduction of forefoot. Etiology, congenital usually isolated and idiopathic. Teratogenic associated with neuromuscular disorder or a complex syndrome, positional abnormal positioning of affected foot in utero. Treatment, immediate non-surgical methods like stretching and manipulation of foot, followed by serial plaster casts, malleable splints or taping. Rightward arrow unsatisfactory response. Rightward arrow 6 months of age but always before 12 months. Majority cases respond to conservative management without surgical repair. Untreated cases rightward arrow further deformation, gait abnormality and development of ulceration. Metatarsus adduction, congenital foot deformity common in firstborn child. No sexual predominance, adduction at tarsometatarsal joint and upward arrow angle between first and second metatarsals, 10% cases associated with acetabular dysplasia, hence careful hip examination required. 3 types. Type I, mild metatarsus adduction characterized by feet that cause correction both passively and actively into abduction. Rightward arrows spontaneously correct themselves and do not need treatment. Type 2, that correct into neutral position by passive or active movement. Rightward arrow RX, orthotasis or corrective shoes, and sometimes plaster casts if initial treatment gives no result. Type 3, rigid feet and do not correct. Rightward arrow RX, managed with serial casts, surgical correction may be needed if significant residual metatarsus. Adductus inferior internal tibial torsion is also a physiologic finding in newborns and spontaneous correction occurs in 95% cases. Slipped capital femoral epiphysis. Displacement of femoral head on femoral neck due to disruption of proximal femoral growth plate, typically in obese children 10 to 16 years. The mean age of presentation is 12 years in girls and 13.5 years in boys. In adolescent boys than girls. Physis, I.E. Physical junction between femoral head and neck weakens during early adolescence due to rapid growth. It is cartilage and not as strong as bone. Obesity worsens stress. Rightward arrow. Physis fracture and femoral disc slips. Additional risk factors, endocrinopathies, e.g. hypothyroidism, growth hormone def. Renal failure and radiation history. Rightward arrow. Mostly B/L disease at early age, S/S. Insidious onset. Dull hip pain or referred knee pain and altered gait/limping with no preceding trauma. Minor trauma can sometimes exacerbate the pain. High degree of suspicion as knee pain, referred pain, and not hip pain is the common presentation with this condition. PT holds affected leg in passive external rotation and loss internal rotation, abduction and flexion, as well as external rotation of thigh when hip is being flexed. DX, plain radiograph of hip in AP and frog, leg lateral view. Rightward arrow. Posteriorly and inferiorly/medially displaced femoral head in relation to femoral neck. Both hips should be imaged for comparison. And contralateral displacement, RX, immediate surgical screw fixation at current degree of displacement to avoid avascular necrosis and chondrolysis. There is no text on this page. Legg-Calvé-Perthes disease, etiology, idiopathic avascular necrosis of femoral head. Can be due to thrombophilia in some patients. Commonly affects boys 4 to 10 years. Peak incidence is at 5 and 7 years, S/S, mild, chronic hip or knee pain of insidious onset as well as antalgic gait, shorter time weight bearing on affected side due to pain, PE, as the disease progresses. Rightward arrow. Abduction and internal rotation markedly. Downward arrow. Proximal thigh atrophy may also be present. DX, requires high index of suspicion as initial X-rays may be negative, leading to initial diagnosis of transient synovitis which may occur after viral infection but resolve in 1 to 4 weeks. Persistent symptoms. Rightward arrow. Repeat imaging as it can take months for concerning changes to appear on X-ray. There is no text on this page. Flattened and fragmented left femoral head. MRI and bone scans can show subtle femoral head necrosis weeks to months earlier than X-ray. Rightward arrow. Early diagnosis, treatment. In general, these patients are managed conservatively with observation and bracing. The surgery may be indicated in cases where the femoral head is not well contained within the acetabulum. PT should refrain from weight-bearing exercises. Hip dysplasia, abnormal development in utero, obvious at birth or may be noticed later when limp is noted. Leg length discrepancy. Over time it can progress to degenerative joint disease, X-ray, poorly formed femoral head. Developmental dysplasia of hip. Developmental dysplasia of the hip. Dislocation of femoral head from the acetabulum. Early diagnosis is critical as treatment initiation before the age 6 months portends favorable prognosis. Delayed diagnosis is one of the most common reasons for malpractice suits against pediatricians due to potential complications such as limp, Trendelenburg gait, scoliosis, arthritis, and avascular necrosis. Risk factors: breech presentation, female sex, white ethnicity, and family history of developmental dysplasia of the hip increase the risk. Most patients, approximately 75%, have no risk factors. Therefore, all infants must have serial hip examinations from birth until they are walking. 1 year, Barlow and Ortolani maneuvers should be performed to assess joint stability. This consists of placing the infant supine with each hip flexed to 90 degrees followed by abduction to feel for dislocatability and adduction to feel for reducibility of an unstable joint. A palpable clunk with either maneuver is alarming sign of hip dislocation and should prompt referral to an orthopedic surgeon. Equivocal signs such as a soft click, leg length discrepancy, or asymmetric inguinal skin fold suggest possible hip laxity. Hip laxity that is present at birth usually resolves by age 2 weeks. Therefore, Imaging is not recommended until / 2 weeks. Infants age 2 weeks, 6 months with abnormal examination should undergo ultrasonography. Developmental dysplasia of hip is bilateral in approximately 20% of patients and thus, both sides should be imaged. X-ray is not helpful until age 4 to 6 months because the femoral head and acetabulum are not yet ossified. After ossification, X-ray is better at showing acetabular development and positioning. A positive Barlow and Ortolani test or abnormal imaging results rightward arrow prompt referral for treatment. The Pavlik harness is a splint that holds the hip inflection and adduction while preventing extension and abduction, which can exacerbate dislocation. It is the treatment of choice age less than 6 months as most hip joints are able to remain in a stable position. After age 6 months, however, the harness is far less successful and reduction under anesthesia is required. CT and MRI can be helpful in perioperative assessment of affected hip but unnecessary for initial screening. There is no text on this page. Femoral neck stress fracture, in athletes and runners, gradual upward arrow in hip pain ESP with activity, pain in passive ROM, ESP external and internal rotation transient synovitis, most common cause of hip pain in children, typically occurring in boys age 3 to 10 years. Cause unknown but usually follows viral infection or mild trauma. Synovial inflammation rightward arrow pain, decreased ROM, and limping. Examination, the affected hip is typically flexed, slightly abducted, and externally rotated. This position maximizes the joint space, and thereby providing some pain relief. Able to bear weight, perform labs to differentiate from septic arthritis and assess severity of inflammation. In contrast to septic arthritis, children with transient synovitis rarely have fever or significant laboratory abnormalities. Appearing, febrile child with 3 or 4 of the findings shown in the table rightward arrow immediate arthrocentesis and 4 antibiotics. Obtain plain radiographs to exclude bony lesions, fractures, and leg calf Perth's disease rightward arrow AP and frog. Leg lateral view of both hips should be obtained to compare both sides for subtle changes, no additional work, up unless symptoms are persistent or worsening, RX, rest and NSAIDs except aspirin rightward arrow follow, up after 1 WK. Usually recover within 1 to 4 weeks without complications rightward arrow persist or worsen rightward arrow reconsider LCP rightward arrow perform MRI pauci, arthritis or pauci, articular onset juvenile idiopathic arthritis is the most common subgroup of juvenile idiopathic arthritis. Serum antinuclear antibodies are usually the only abnormality. Although pauci arthritis can present with a morning limp, it typically occurs in a female toddlers and really involves the hip. Rickets. Although breastfeeding is the gold standard nutrition 1 year but exclusive breastfeeding or homemade nutrition are inadequate in vitamin D if child is not taking fortified baby food or formula rightward arrow given vitamin D 400 IU daily to prevent rickets, RX of rickets, vitamin D repletion with 1000 to 2000 IU daily osteogenesis imperfecta, most commonly inherited from autosomal dominant mutation of COL1A1, varying spectrum of severity, mild, type I, moderate, type 3, 9, to fatal. Perinatal, type 2, suspect in anyone with blue sclera, other manifestations depend on severity of disorder, recurrent fractures. Fractures, easy bruisability, hypotonia and hearing loss normal intelligence, dentinogenesis imperfecta rightward arrow in many PTS rightward arrow blue, gray to yellow-brown discolored dentin shining through translucent and weak enamel both primary and permanent teeth are affected Kawasaki disease, acute vasculitis of small and medium-sized vessels, peak age 18 to 24 months and almost all cases 5 years and rarely in adults greatest among East Asian ethnicity. Persistent release of pro-inflammatory cytokines rightward arrow prolonged high fever minimally responsive to antipyretics, irritability and systemic inflammation, diagnosis on clinical grounds. Fever 4/=5 days and any 4 of 5 of the following, usually U/L least consistent finding. Spares limbus. Erythema, fissured lips and strawberry tongue, injected pharynx desquamation of hand and feet, usually late finding, PTS with atypical presentation rightward arrow support with following labs, elevated CRP and ESR leukocytosis with neutrophilia, as opposed to lymphocytosis in viral infections, reactive thrombocytosis sterile pyuria on urine analysis, D/D, scarlet fever, similar presentation including fever, rash, strawberry tongue, and cervical LAD, but ocular manifestations uncommon. Pharyngitis more common and sandpaper rash that spares palms and sole staphylococcal scalded skin syndrome, more common in newborns rightward arrow fever, rash, irritability rightward arrow diffuse erythema typically begins around mouth and spreads rapidly throughout body rightward arrow flaccid 2 days later in flexural areas and plus VE Nikolsky's sign hand, foot, and mouth disease, fever, vesicles in oral mucosa and tongue, small, tender and cutaneous lesions on palms and soles. Caused by Coxsackie virus. Self, limited in 2 to 3 days, Rx, aspirin plus 4 immunoglobulin preferably started within 10 days of symptom onset to prevent complications. Systemic inflammation resolves in 12 days if untreated but can lead to CV complications. Echo performed at the time of diagnosis and repeated 6 to 8 weeks later. To look for changes that may require close monitoring and prolonged therapy, complications, coronary artery aneurysm, myocardial ischemia and infarction, acquired torticollis, also known as Rhineck rightward arrow neck twisting due to asymmetric muscle activity, most common causes, upper respiratory infections, minor trauma, cervical lymphadenitis, more serious causes, retropharyngeal abscess and atlantoaxial subluxation. Cervical spine radiographs should be obtained in children presenting with torticollis to ensure no spine fracture or dislocation, which requires extreme caution. Atlantoaxial instability in Down syndrome patients, 10 to 15% cases of Down syndrome, 1 to 2% symptomatic, excessive laxity in posterior transverse ligament rightward arrow upward arrow mobility between atlas, C1, and axis, C2, SX, progressive over several weeks and result from compression of spinal cord rightward arrow behavioral symptoms, torticollis. Urinary incontinence and vertebrobasilar symptoms like vertigo, dizziness, and diplopia. PE, UMN symptoms like leg spasticity, upgoing plantar, hyperreflexia and clonus usually present. Down syndrome PTS are normally hypotonic, may remain hypotonic or may have upward arrow tone due to UMN lesion signs, DX, suspected on physical exam and diagnosed with lateral radiographs of cervical spine inflection, extension, and in neutral position. Open mouth radiographs helpful in visualizing odontoid, RX, surgical fusion of first and second cervical vertebrae spondylolisthesis. Chronic back pain is common in adults and usually benign in nature, but chronic back pain in children needs careful search of the cause. As back pain in children is usually due to organic causes, spondylolisthesis is a developmental disorder characterized by a forward slip of vertebrae, usually L5/S1. It is usually presents in pre-adolescent children with chronic back pain and neurologic dysfunction in combination with palpable step-off at lumbosacral area. Step-off is palpable if condition is severe. Lytic bone lesions in children, D/D, infectious, Brody abscess from osteomyelitis, endocrine, hyperparathyroid osteitis, fibrosis cystica, neoplastic, Ewing sarcoma, Langerhans cell histiocytosis, metastases, and idiopathic, benign bone cyst, aneurysmal bone cyst. Etiologies. Lytic bone lesion plus hypercalcemia, D/D, hyperparathyroid state. Parathyroid adenoma is the most common cause of primary hyperparathyroidism, occurs in PTS 50-yo, lytic bone neoplasm. Langerhans cell histiocytosis, also known as Langerhans cell granulomatosis, histiocytosis X, cause solitary, lytic, long bone lesions, Eosinophilic granuloma, the least severe form of histiocytosis X, generally in children and young adults. Solitary bone lesion, may be painful, have overlying tender swelling and cause pathologic fractures, may be locally destructive, typically resolve spontaneously and therefore regarded as benign and treated conservatively. Pointers: most common cause of osteomyelitis in children is hematogenous seeding by Staph aureus. It tends to affect metaphysis and spares epiphysis contents. Stress fracture, 2 hip fracture, 3 clavicular fracture, 3 supracondylar fracture of humerus, 3 scaphoid fracture, 4 minor ligament sprain, 5 compartment syndrome, 5 rheumatology/orthopedics and sports surgery. Stress fracture, local swelling may also be present. I.E. Rest, bone responds to mechanical stress by remodeling, but abrupt upward arrow in intensity, duration, or frequency of physical activity, without adequate rest, rightward arrow repeated tension or compressive stress to bone. Rightward arrow microfractures that eventually coalesce within cortical bone. Categorized as activity-related, e.g. excessive training and improper footwear; biomechanical, e.g. weak calf muscles, high, arched feet etc., or metabolic, e.g. demineralized bone from hormonal or nutritional diseases. Sudden increase in repeated tension or compression without adequate rest. Rightward arrow eventually breaks the bone. Tibia major weight bearing bone in the leg. Rightward arrow patients usually develop medial tibial stress syndrome, I.E. shin splints with no tibial tenderness on palpation. Rightward arrow further activity. Rightward arrow complete or incomplete fracture, resulting in pain to palpation of tibia. Classically occur in anterior part of middle third of tibia in jumping sports and posteromedial of distal third of tibia in runners. Metatarsal stress fracture, displaced hairline fracture, typically occur in athletes and military recruits due to sudden and drastic upward arrow inactivity. Second metatarsal, most commonly involved as subjected to significant extremes of loading during gait. Slow onset foot pain, initially with activity but later during rest. 2-point tenderness over. Affected metatarsal bone scans and MRI are done if plain films don't demonstrate fracture. Fractures of second, third, and fourth metatarsals, managed conservatively. As surrounding metatarsals act as splints and non-union is uncommon. Rest and pain control are most important. Hard sole shoe and light activity may be resumed immediately. Plaster casting used for PTS with more persistent pain following more conservative treatment. Fracture of fifth metatarsal, surgical intervention reserved for fracture of fifth metatarsal, such as Jones fracture, or for displaced fracture not amenable to closed reduction. Diagnosis, made clinically on examination with pain at a specific area, upward arrow with jumping or running, associated with local swelling and point tenderness to palpation. X-rays frequently normal but can reveal periosteal reaction in the site of fracture. MRI or bone scans. Rightward arrow best tests. Treatment, rest and healing of stress fracture. Hip fracture, can be intracapsular, femoral head or neck, or extracapsular, e.g. intertrochanteric or subtrochanteric. Intracapsular is at higher risk of avascular necrosis and extracapsular is at greater need of implants like nails, rods. Surgical repair should be done as soon as feasible to reduce pain, minimize complications, and reduce length of hospital stay. Surgery can be delayed up to 72 hours to address unstable comorbid conditions, but longer delay is associated with more complications. Surgical traction has been advocated in those who require delayed surgical repair, but it does not relieve pain or improve surgical outcome. Clavicular fracture, one of the most commonly injured bones, mostly injured in middle third, classically during athletic events and mostly after a fall on outstretched hand or a direct blow to shoulder. S/S, pain and immobility of affected arm. Rightward arrow contralateral hand is classically used to support weight of affected arm. Rightward arrow shoulder on affected side is displaced inferiorly and posteriorly. Careful neurovascular exam should be performed due to close Proximity to subclavian artery, perform angiogram, and brachial plexus, motor exam of arm and hand usually sufficient, may rarely perform nerve conduction study, RX, fracture of middle, third, most common, rightward arrow usually treated non-operatively with brace, ice, and rest, rightward arrow early range of motion and strengthening recommended to prevent loss of motion at shoulder in non-operative cases, fracture of distal third of clavicle, rightward arrow open reduction and internal fixation to prevent non-union. Supracondylar fracture of humerus, most common fractures in pediatric population. First two are most common complications. Impingement of brachial artery results in a loss of brachial and radial artery pulses. Distal perfusion should always be assessed on examination. Motor and sensory functions should also be assessed due to the risk of median nerve injury. Common because supracondylar area is thin and weak due to physiological remodeling in childhood, compartment syndrome, mosaic application, also supracondylar fracture of humerus. Ischemia and infarction from compartment syndrome can lead to Volkmann contracture. Limb length discrepancy is a common complication of proximal humerus and distal forearm fractures. However, the distal physis, growth plate, of the humerus contributes minimally to longitudinal growth due to limited remodeling. As a result, patients with supracondylar fracture of humerus are at increased risk of cubitus varus deformity. RX, treatment consists of analgesia and immobilization. Displaced fractures, rightward arrow orthopedic consultation. Neurovascular injury often resolves after orthopedic alignment and immobilization. Treated promptly, rightward arrow good prognosis. Scaphoid fracture, most commonly fractured carpal bone usually across waist of scaphoid bone. Proximal fracture fragment vulnerable to avascular necrosis due to tenuous blood supply, after a fall on outstretched arm with a dorsiflexed wrist. 95*S/S, pain at wrist joint. Tenderness at anatomic snuff box, most sensitive. Sensitive. Minimally decreased ROM, unless dislocated, decreased grip strength and possible swelling. DX, scaphoid views, plain X-ray, full pronation and ulnar deviation to better expose scaphoid are necessary to avoid missing fracture. Initial X-ray may be normal or show radiolucent line in non-displaced fracture, I.E. Displacement 2 mm and no angulation, RX, wrist immobilization with thumb spica cast in all non-displaced suspected or proven fractures for 6 to 10 weeks to avoid non-union, and repeat X-ray in 7 to 10 days or perform immediate advanced imaging like CT scan or MRI if patient cannot tolerate immobilization or immediate diagnosis is needed to distinguish fracture and ligament rupture. Fracture displacement, rightward arrow open reduction and internal fixation. Minor ligament sprain, Rice treatment, rightward arrow I.E. Rest, ice, compression, and elevation. Compartment syndrome, due to upward arrow pressure in compartment due to edema and / or bleeding. Common in forearm and calf but can occur in any compartment. 5ps rightward arrow pain, pallor, paresthesia, pulselessness, and pressure. Predisposing factors, direct trauma, prolonged compression of extremity and recent revascularization after acute limb ischemia. Considerable variation in signs and symptoms and high index of suspicion is needed to make diagnosis, DX, confirmed by measuring compartment pressures in affected extremity. But in high-risk PTS, e.g. limb revascularization, can be diagnosed clinically by SX of CS, pain, swelling and paresthesia. Time to fasciotomy most critical prognostic indicator and should be performed early. Supportive measures taken to maintain perfusion pressures by keeping the limb at level of torso, not higher or lower. Contents physiology. 4 reticulocytes. 4 pathologic RBC forms. 4 Howell-Jolly bodies. 4 Heinz bodies. 4 anemia. 4 evaluation of anemia. 4 microcytic hypochromic anemia. 4 iron deficiency anemia. Anemia. 6 thalassemia. 6 lead poisoning in adults. 7 acquired sideroblastic anemia. 7 macrocytic anemia. 7 folate deficiency. 8 pernicious anemia. 8 normochromic normocytic anemias. 9 intrinsic hemolytic anemia. 9 extrinsic hemolytic anemia. 14 non-hemolytic normochromic normocytic anemias. 14 bleeding disorders. 15 coagulation disorders. 16 coagulation pathway. 16 hemophilias. 16 vitamin K deficiency. 17 platelet disorders. 18 thrombocytopenia. 18 immune thrombocytopenia. 18 thrombotic thrombocytopenic purpura. Purpura. 19 thrombophilia/deep venous thrombosis. 20 workup for cause. 20 factor V Leiden mutation. 20 treatment of DVT. 21 hemodynamically stable patient. 21 management of provoked DVT after surgery. 22 threshold for RBC transfusion. 22 blood transfusion reactions. 23 febrile non-hemolytic. 24 acute hemolytic reaction. 24 delayed hemolytic reaction. 24 anaphylactic reaction. 24 indications for specialized RBC treatments. 25 look reduced. 25 calcium gluconate infusion. 25 warming. 25 co-poisoning. 26 frostbite. 26 multiple myeloma. 27 Waldenstrom's macroglobulemia. Macroglobulemia. 27 leukemias. 28 lymphadenopathy. 28 lymphoid neoplasms. 28 acute lymphoblastic leukemia. 28 chronic lymphocytic leukemia. 29 hairy cell leukemia. 29 myeloproliferative disorders. 30 chronic myelogenous leukemia. 30 polycythemia vera, PV. 30 obstructive sleep apnea. 31 androgen abuse. 31 hereditary hemochromatosis. 32 superior vena cava syndrome. 32 head and neck squamous cell California. 32 prostate cancer. 32 spinal cord compression. 33 epidural spinal cord compression. 33 tumor lysis syndrome. 33 cancer-related anorexia/cachexia syndrome. CACS. 34 pain management in cancer patients. 34 chemotherapy-induced nausea and vomiting management. 34 anticoagulants and their MOA. 35 heparin-induced thrombocytopenia. 35 type 1 hit. 35 type 2 hit. 36 warfarin-induced skin necrosis. 37 definitions. 37 adjuvant therapy. 37 induction therapy. Therapy. 37 consolidation therapy. 37 maintenance therapy. 37 neoadjuvant therapy. 37 salvage therapy. 37 Hematology and oncology. IM physiology. Reticulocytes have slightly bluish tint and stain with methylene blue. Pathologic RBC forms Howell Jolly bodies. Nuclear remnants in RBCs typically removed by spleen, indicate splenectomy. Functional hypofunctioning of spleen due to autosplenectomy, infiltrative disorders of spleen, or splenic congestion. Peripheral blood smear, appear as single, round, blue inclusions on right stain Heinz bodies, in G6PD def. Rightward arrow HB oxidized rightward arrow forms insoluble precipitants I.E. Heinz bodies, peripheral blood smear, appear in RBCs after staining with dyes such as crystal violet. Anemia. Evaluation of anemia. Microcytic hypochromic anemia, most common rightward arrow iron deficiency anemia. The differential diagnosis should include iron deficiency, Decreased intake or increased blood loss. Chronic GI bleeding is the most common cause in adult male and post-menopausal woman. Look for occult blood in stool. Defective utilization of storage iron, anemia of chronic disease. Reduced globin production, thalassemia and other hemoglobinopathies do not respond to iron. Supplementation. Beta thalassemia minor presence with modest anemia, HCT ranges from 28 to 40%, and MCV between 55-75 FL. Common in Mediterranean descent. Reduced heme synthesis, lead poisoning, sideroblastic anemia. Iron deficiency anemia, upward arrow RDW is the earlier lab finding in iron def. Anemia occurs in nutritional deficiencies as nutrient levels available for RBC synthesis vary throughout the day, resulting in cells of varying sizes. RDW 20% suggest iron def. Anemia. Normal in thalassemia I.E. 12 to 14% thalassemia, beta, thalassemia is more common in Mediterranean descent and alpha is more common in Southeast Asia. Majority of alpha and beta thalassemia minor cases are asymptomatic, often incidental finding, have varying degrees of anemia. Microcytosis, target cells and teardrop cells on peripheral smear, MCV 75 FL, normal RDW as all cells are same size and width. Thalassemia minor is often confused with iron deficiency anemia. Both thalassemia traits have microcytosis out of proportion to the degree of anemia, HB10G/DL, and disproportionately normal or high RBC count. This typically results in Menser index, MCV/RBC, 13. Hematocrit is usually 30% in PTS with thalassemia minor. Iron def. Anemia has low RBC count, and rarely becomes microcytic until HB10G/DL or hematocrit 30%. Menser index 13. Lead poisoning in adults. Plumbing, mining, painting, paper hanging, auto repair. Signs of acute poisoning. Signs of chronic lead poisoning, nonspecific symptoms, e.g. fatigue, irritability, insomnia, HTN, motor and sensory deficits, nephropathy. Ray fluorescence to measure bone lead. CONC. Lead is readily absorbed via respiratory, in adults, or gastrointestinal, in children. Tracks, 99% bound to RBCs and disrupt HB synthesis at high levels. 80 mcg/dl, rightward arrow. Microcytic anemia, RX, via chelation therapy. Acquired sideroblastic anemia, due to pyridoxine-dependent impairment of early steps of protoporphyrin synthesis. Isoniazid is a known cause of pyridoxine deficiency. Rightward arrow. Give pyridoxine supplementation. 2 groups of RBC population, hypochromic and normochromic, dimorphic RBC population, iron studies, upward arrow. Serum iron and downward arrow. TIBC. Rightward arrow. Differentiate iron def from sideroblastic anemia. Bone marrow sampling, confirm diagnosis by showing ringed sideroblasts, a specific DX in this type of PTS, Pappenheimer bodies. Iron-containing inclusion bodies found in peripheral RBCs result from phagosomes that engulf excessive amount of iron typically seen in sideroblastic anemia. Macrocytic anemia. Megaloblastic anemia. Rightward arrow. Due to impaired DNA synthesis. Rightward arrow. MCV 110 FL, low reticulocyte count, macrovelocyte RBCs, hypersegmented neutrophils, mean lobe count 5, anisocytosis and poikilocytosis. Non-megaloblastic. Normal, increased or decreased reticulocyte count, peripheral blood smear and reticulocyte count are the best next step in management. Rightward arrow if upward arrow. MCV. Rightward arrow. Folate and B12 levels. Rightward arrow if low. Rightward arrow. Further tests to elucidate cause. MCV 110 FL. Favor megaloblastic anemia. Vitamin B12, total body stores, 2 to 5 milligrams. Minimum daily requirement, 6 to 9 g/day. Dietary source, only animal products, meat and dairy. Deficiency, 4 to 5 years of pure vegan diet to cause deficiency. Folate deficiency, occurs within 4 to 5 months of dietary deficiency. Alcoholic abuse rightward arrow impair enterohepatic cycle and folic acid absorption rightward arrow develop folic acid def. Rightward arrow can develop megaloblastic anemia in 5 to 10 weeks of alcohol abuse. Some medicines like phenytoin, primidone and phenobarbital impair folic acid absorption rightward arrow folate def. Rightward arrow folic acid supplementation can effectively prevent this condition. Trimethoprim and methotrexate rightward arrow inhibit dihydrofolate recutase rightward arrow megaloblastic anemia, basophilic stippling, ribosomal precipitates that form varying size of blue granules in RBC cytoplasm, non-specific sign rightward arrow lead poisoning, alcohol abuse, thalassemias pernicious anemia, most imp cause B12 deficiency rightward arrow neurologic deficits and achlorhydria most common cause of B12 deficiency in PTS of Northern European descent. There can be presence of other autoimmune diseases like autoimmune thyroid problems and vitiligo. Pernicious anemia causes B12 def by 2 ways. 1. By the presence of if antibodies to PTS develop chronic atrophic gastritis rightward arrow downward arrow production of if by gastric parietal cells. Atrophic gastritis upward arrow the risk of intestinal type gastric Ca and gastric carcinoid tumors by 2 to 3 times over general population rightward arrow monitor with periodic stool testing for presence of blood in stool. DX confirmation, presence of if antibodies, pernicious anemia and myelodysplastic syndromes, more common in elderly, present with pancytopenia and macrocytosis, upward arrow MCV, differentiated by careful examination of peripheral smear and bone marrow for dysplastic cells, homocysteine upward arrow in folate and B12 def. Homocysteine and methylmalonic acid upward arrow in B12 def. Normochromic normocytic anemias. Intrinsic hemolytic anemia. Hereditary spherocytosis HB released from list RBCs rightward arrow bind. Haptoglobin rightward arrow haptoglobin HB complex cleared by liver rightward arrow haptoglobin downward arrow to undetectable levels. RBC hemolysis rightward arrow upward arrow LDH and indirect bilirubin largely in reticuloendothelial system, LN and spleen. Normal to slightly low haptoglobin, slightly upward arrow LDH, and upward arrow indirect bilirubin. Coombs test is performed to confirm the diagnosis even if negative and suspicion is high. Rightward arrow perform micro, Coombs test to confirm diagnosis. Warm, IgG, cold, IgM, some intravascular hemolysis can occur ESP. In IgM mediated. Can be autosomal recessive or due to spontaneous mutation. Rightward arrow defect is most common in ankyrin gene. Rightward arrow abnormal spectrin protein, due to membrane loss and RBC dehydration. Upward arrow reticulocytosis, upward arrow RDW, normal or low MCV calcium bilirubinate. Rightward arrow can lead to cholecystitis. Rightward arrow perform cholecystectomy. Most common hereditary hemolytic anemia in Northern European population. Hemolysis rightward arrow hyperbilirubinemia manifests as dark urine, cola-colored, jaundice and pigment gallstones, calcium bilirubinate. Reticulocyte count is normally high in hemolytic anemia, but if it presents in neonates, they are unable to produce appropriate erythropoiesis in response to anemia. Rightward arrow severe anemia and need of transfusion. Maleimide binding test, flow cytometry, is the gold standard of diagnosis. Now, in case of cholecystitis, remove gallbladder. Splenectomy also improves gallstones. Complications of splenectomy: immediate, hemorrhage, post-op infection, injury to nearby organs. Long-term, sepsis with encapsulated bacteria ESP. Pneumonia. Risk of pneumococcal sepsis is present 30 years and more after splenectomy. Rightward arrow prevention, anti-pneumococcal, conjugate vaccine, Haemophilus and meningococcal vaccines several weeks before surgery, and daily oral penicillin prophylaxis for 3 to 5 years post-splenectomy or until adulthood. For pediatric PTS, rightward arrow penicillin prophylaxis may be given lifetime or antibiotics made available at home for immediate treatment of any significant fever. Glucose 6-phosphate dehydrogenase deficiency. G6PD activity may be used as a screening test, but levels are usually normal during the episode, as G6PD deficient RBCs are hemolyzed early in the episode and reticulocytes with normal G6PD are abnormally high. Rightward arrow better to retest after 3 months of episode. Paroxysmal nocturnal hemoglobinuria usually presents in 4th decade of life with following clinical presentations: an acquired genetic defect that results in lack of the glycosylphosphatidylinositol anchor, which connects proteins, including CD55 and CD59, to the cell surface. Rightward arrow absence of CD55 and CD59 from cell surface. Rightward arrow activation of complement membrane attack complex. Rightward arrow hemolysis. Both intravascular and extravascular hemolysis. Patients with hemolytic anemia have a tendency for venous thromboembolism. Thromboembolism, but PNH patients are at particular risk. ESP. Intra, abdominal and cerebral vein sickle cell anemia. Earliest manifestation of vaso-occlusion in sickle cell anemia, 6 months to 2 years. Rightward arrow warrant complete workup for previously asymptomatic SCD patho, vascular necrosis of metacarpals and metatarsals, osteolytic lesions on X-ray, polychromasia on peripheral blood smear, nuclear remnants usually removed by spleen but downward arrow spleen function. Rightward arrow Howell, Jolly bodies daily in all PTS to correct underlying folate def. Chronic extravascular and intravascular hemolysis. Hydroxyurea works by stimulating erythropoiesis, is primitive. Erythroid precursors. Rightward arrow upward arrow HbF, rightward arrow downward arrow HbS. Primary dose, limiting S/E is myelosuppression, neutropenia, thrombocytopenia, anemia, but is otherwise safe. Exchange transfusion is used to prevent stroke and also one of the primary treatments of stroke in PT with SCD. Rightward arrow does not reverse, rather prevent further stroke by downward arrowing. No. Of sickled RBCs in blood. Sickle cell trait, painless microscopic or gross hematuria is the most common renal finding in PTS with sickle cell trait. Hyposthenuria, found in sickle cell disease and also common but less severe in patients with sickle cell trait. RBC sickling in vasa recta of inner medulla. Rightward arrow impairment of countercurrent exchange and free water. Reabsorption. Rightward arrow impairment in kidneys' ability to concentrate urine. Rightward arrow nocturia and polyuria. Less commonly, UTIs may occur ESP. In pregnancy. Renal papillary necrosis can occur. Rightward arrow massive hematuria, but episodes usually mild and resolve spontaneously. U/A, normal appearing RBCs. Distal renal tubular acidosis can occur due to tubular damage. Acute severe anemia in SCD, 1%, aplastic crisis, no splenomegaly. Anemia typically severe HB6G/DL, pallor, weakness, fatigue plus functional systolic murmur due to hyperdynamic blood flow, WBC and platelets usually normal, usually before age 15, as parvo outbreaks common in school, aged children. Blood transfusion mainstay of treatment. Splenic sequestration crisis, occurs periodically, beginning as early as infancy. Acute anemia, manifests as upward arrowing fatigue and hypotension in severe cases, low to absent haptoglobin on labs. Autoinfarction of spleen. PTS with SCD have infarcted spleens by first 18 to 36 months of life. Rightward arrow Howell, Jolly bodies on peripheral blood smear, hence, PTS are at upward arrow ed risk of sepsis from S. Pneumonia, H. Influenza, N. Meningitides, vaccination has downward arrow ed incidence of bacteremia. Despite vaccination, S. Pneumonia by far remains the most common cause of bacteremia in SCD PTS, usually from non-vaccine serotypes. PTS with SCD can be prevented from invasive infections by encapsulated organisms through vaccinations. E.G. Conjugate S. Pneumonia vaccine. Twice daily prophylactic penicillin till they reach 5 years. Avascular necrosis, up to 50% PTS with SCD developed by adulthood, commonly affected sites, humeral and femoral head, pathogenesis, sickling, microinfarctions and bone hyperplasia. S/S, restricted ROM, significant pain, no erythema or tenderness to palpation, difficulty bearing weight, RX, pain management and limitation of weight bearing, with surgical intervention if conservative fails, E.G. Joint reconstruction, electrophoresis. Extrinsic hemolytic anemia, autoimmune hemolytic anemia. High dose to downward arrow autoantibodies, warm agglutinin AIHA, splenomegaly due to erythrocyte entrapment and reticulocytosis usually present, blood smear, spherocytes, microspherocytes, elliptocytes, and upward arrow no. Of polychromatophilic cells, e.g. reticulocytes, non-hemolytic normochromic normocytic anemias, chronic kidney disease or end-stage renal disease, CKD, rightward arrow downward arrow erythropoietin production, rightward arrow normochromic, normocytic, hypoproliferative anemia, rightward arrow give erythropoietin supplementation, DOC, rightward arrow new RBCs, rightward arrow iron utilized, rightward arrow rapid depletion of body's iron stores. Additionally, because of chronic illness, rightward arrow microcytic hypochromic anemia, iron deficiency anemia. Because of possibility of developing subsequent iron def anemia, rightward arrow iron stores should be evaluated prior to erythropoietin supplementation. Treatment of choice in PT with iron def anemia undergoing dialysis, rightward arrow for iron prep like iron dextrin and then recombinant erythropoietin. All patients with chronic renal failure and hematocrit 30%, or hemoglobin 10G/DL, are candidates for recombinant erythropoietin therapy after iron deficiency has been ruled out. Erythropoietin is also indicated in hemodialysis patients who have symptoms attributed in part to anemia. Some of the most common side effects of erythropoietin therapy are: 1. Worsening of hypertension. Approximately 30% of patients, 20 to 50% of patients receiving 4 erythropoietin will have more than a 10 mmHg rise in diastolic BP. Less common with SC route as compared to 4 route. Even hypertensive encephalopathy can occur when there is a rapid rise in BP. MOA is unclear. RX, fluid removal, by dialysis, and use of anti-hypertensive drugs, beta blockers and vasodilators are preferred. Prevention, slowly raise the hematocrit, with a goal hematocrit of 30 to 35%. 2. Headaches, 15% patients. 3. Flu-like syndrome, 5% of patients. Responsive to anti-inflammatory drugs, and is less commonly seen with SC erythropoietin administration. 4. Red cell aplasia, rare, but potential side effect. Bleeding disorders. Coagulation disorders, coagulation pathway. Hemophilias. Female carriers can be mildly symptomatic. Can occur with minor trauma or without trauma. Begin during toddlerhood when child is active and ambulatory. Recombinant or purified product, hematuria, cola-colored urine, common but renal impairment does not occur, can affect almost every organ system and result in long-term complication, hemophilic arthropathy, late complication in both hemophilias. Caused by iron/hemosiderin deposition, rightward arrow synovitis and fibrosis within joint, and not exactly caused by microtrauma. Other mechanisms may be involved. S/S, chronic worsening joint pain and swelling, can result in contracture and limited ROM, more common in PTS with recurrent hemarthroses, may be visible on plain X-ray. MRI is helpful in making earlier diagnosis and characterization of degree of joint damage. Cannot be entirely prevented, but early prophylactic treatment with factor concentrates rightward arrow significantly downward arrow risk of developing arthropathy. Vitamin K deficiency. Fat-soluble vitamin A, D, E, K, exocrine pancreatic insufficiency, rightward arrow impaired fats and fat soluble vitamin absorption, rightward arrow, pancreatic enzyme replacement and fat-soluble vitamin supplementation, important role in coagulation, rightward arrow, acts as cofactor in enzymatic carboxylation of glutamic acid residues on prothrombin complex proteins, deficiency, hepatocellular disease, rightward arrow, loss of storage sites, liver normally stores a 30-day supply of vitamin K, acutely ill person with underlying liver disease, e.g. alcoholic, can become vitamin K depleted in 7 to 10 days. NPO state and broad spectrum antibiotics also contribute to quick depletion, leads to downward arrow coagulation factors 2, 7, 9, 10, and protein C and S, initially increases PT, followed by prolongation of PTT, in newborns. Newborns who do not receive vitamin K injection, severe deaf. Upward arrow PT and PTT, mild deaf. Upward arrow PT and normal PTT diagnosed by reversal of symptoms with vitamin K administration, RX, administer vitamin K, rightward arrow rapidly replenishes the stores in 8 to 10 hours. Fresh frozen plasma, rightward arrow used for management of acute hemorrhage in interim. Platelet disorders, thrombocytopenia. Immune thrombocytopenia can occur at any age, most commonly affected age group, 2 to 5 years. Normal HCT and leukocyte count. Usually spontaneous recovery within 6 months, hence, treat only if bleeding plus VE regardless of platelet count. Autoimmune disorder, rightward arrow, upward arrow, platelet destruction, in spleen, and inhibition of megakaryocyte platelet production due to IgG autoantibodies against platelet membrane glycoproteins, common cause of isolated thrombocytopenia, diagnosis of exclusion. Megakaryocytes are seen on peripheral blood smear, other than history, PE, CBC, and examination of blood smear. Only other recommended tests in PTS with presumptive idiopathic thrombocytopenic purpura are HIV and HCV. If risk factors exist, as 5 to 10% patients with chronic HIV may present with isolated thrombocytopenia before any other symptoms develop. But before this, it is also important to rule out pseudothrombocytopenia due to platelet clumping by EDTA, abciximab administration, or inadequate anticoagulation. Anticoagulation of blood sample. Bone marrow biopsy may be needed in PTS with negative tests and unexplained thrombocytopenia. Treatment of underlying causes can alter the course of 2 degrees IDP. Splenectomy is the last resort for catastrophic bleeding or chronic IDP that is refractory to IVIG or corticosteroids. Idiopathic thrombocytopenic purpura and immune TP are same or different. Thrombotic thrombocytopenic purpura. PEX removes PT's plasma and replaces it with donor plasma. Rightward arrow removes autoantibodies and replenishes ADAMTS13. Life threatening condition, rightward arrow without emergent PEX. Rightward arrow mortality rate is 90%. Downward arrow ADAMTS13. Rightward arrow long chains of VWF accumulate on endothelial wall. Rightward arrow trap platelets. Rightward arrow generate thrombi in areas of high shearing force, e.g. arterioles, capillaries. HIV is a risk factor for this, but most cases are either idiopathic or 2 degrees to drug toxicity. Peripheral blood smear is done to check the presence of schistocytes, as present in almost all cases, and absence suggests some other diagnosis. Diagnosis is based mainly on clinical and laboratory findings. Combo of thrombocytopenia and hemolytic anemia in the absence of alternative cause is enough to make diagnosis and start treatment with plasma exchange thrombophilia/deep venous thrombosis. Workup for cause, careful history and PE if possible. Discontinue vitamin K antagonist like warfarin prior to evaluating protein S levels. Testing is recommended in young, age 45, patients with a first-time unprovoked DVT/PE, patients with recurrent DVT/PE, and patients with unusual sites of thrombi, e.g., cerebral, mesentery, portal veins. Lab studies including CBC, comprehensive metabolic panel, coagulation studies, APTT, PT/INR, ESR, hemocold stool testing and CXR. Rightward arrow further testing based on above results. Absence of clear provoking factor, e.g. recent procedure, immobilization, in PTS with first episode of VTE rightward arrow refer for age, appropriate cancer screening, e.g. colonoscopy, mammography, and CXR in most PTS with first episode of unprovoked VTE, concerns for occult malignancy, e.g. due to suggestive SX like weight loss or pain, or recurrent or multiple site VTE rightward arrow extensive cancer screening, e.g. CT chest, abdomen, pelvis, factor V Leiden mutation, most have AD point mutation in gene 4. Factor V that makes gene unable to respond to activated protein C, an innate anticoagulant. This mutation leads to slowed degradation of activated factor V, VA, rightward arrow continued thrombi. Formation slow degradation of activated factor 8, VIIIA, as factor VA acts as a cofactor to degrade VIIIA. Treatment of DVT. Therapeutic. Therapeutic INR equals 2 to 3 hemodynamically stable patient, anticoagulants that can be used, warfarin with heparin initially or direct factor XA inhibitors. Contraindications to anticoagulation, significant active bleeding / massive GI bleeding, recent surgery but can be started in hemodynamically stable patient. Patient as early as 48 to 72 hours after surgery, acute hemorrhagic stroke indications for rivaroxaban, acute DVT or PE, recurrent or refractory DVT, if PT does not want daily injection, heparin, or has difficulty with dietary restriction and frequent INR monitoring, warfarin, it has same efficacy as low molecular weight heparin and warfarin IVC filters. Indications, contraindications to anticoagulation and recurrent or extending thromboembolism while PT is fully anticoagulated. I.E. INR between 2 to 3, placed via a transvenous approach, preferably place retrievable filter that can be removed when no longer needed. Short-term complications, bleeding, infection and thrombus at puncture site. Long-term complications, filter migration or erosion into surrounding structures and recurrent thrombus, including one that extends into IVC and surrounds the filter. Trousseau syndrome, hypercoagulable state rightward arrow superficial venous thrombosis at unusual sites, e.g. arm. Chest area, rightward arrow associated with pancreatic, most common, lung, prostate, stomach and colon cancers and acute leukemias. Rightward arrow perform CT scan of abdomen to rule out prostate cancer and then go for further tests. Management of provoked DVT after surgery. Provoked DVT due to recent surgery is likely to be treated for 3 months. Warfarin and 4 unfractionated heparin, start on same day. Preferred long-term anticoagulant for PTS with end-stage renal disease. Low molecular weight heparin and rivaroxaban RCI in ESRD. Heparin is continued for initial 4 to 5 days till the therapeutic INR, goal 2 to 3, is reached. Threshold for RBC transfusion. Blood transfusion reactions medical emergency. Due to immune complex deposition oliguric RF plasma free HB greater than or equal to 25 mg/dl repeat type and cross-match show mismatch. Possibly due to clerical error IgG antibodies CXR, B/L interstitial infiltrates blood transfusion reactions associated with hypotension. Adverse reaction to blood transfusion occur despite multiple tests and inspections of blood. Febrile non-hemolytic, blood-stored rightward arrow leukocytes release cytokines. Rightward arrow transfused rightward arrow fever, chills and malaise. Prevention, use leukoreduced blood products. Treatment, stop transfusion to exclude other serious reactions. Administer antipyretics, avoid aspirin in thrombocytopenic patients, and use leukoreduced blood in future acute hemolytic reaction, S/S, discomfort at infusion site. Management, immediate cessation of transfusion while maintaining 4 access for fluids, normal saline, and supportive care. Delayed hemolytic reaction, due to anamnestic antibody response to red blood cell antigen to which person was previously sensitized, ABs are undetectable prior to transfusion but reappears rapidly following transfusion, low-grade hemolysis, no treatment usually required, anaphylactic reaction, S/S, hypotension, difficulty breathing, rightward arrow LOC, shock, and respiratory failure. Management: stop transfusion immediately, give IM epinephrine, circulatory and respiratory support with vasopressors and mechanical ventilation. Histamine blockers and glucocorticoids should also be administered. Future transfusions: IgA deficient plasma and washed red cell products. Indications for specialized RBC treatments: look, reduced washed to remove as much plasma as possible as it contains proteins including IgA and can cause allergic reaction. Reduce the No. of transfused leukocytes through filtering, or other methods like saline washing, freezing and deglycerolizing or buffy coat removal. It also reduces the risk of HLA alloimmunization and transmission of CMV. Calcium gluconate infusion, used to avoid or treat severe hypocalcemia following massive transfusion, specially occurs in PTS who have received equivalent of more than 1 blood volume of blood transfusion or packed RBCs over 24 hours. Occurs because of presence of citrate which chelates calcium and magnesium in plasma, used as anticoagulant in whole blood. For transfusions, rightward arrow cause paresthesias, warming, when massive blood transfusion is needed, rightward arrow to prevent hypothermia. Co-poisoning: non-smokers have low levels, 3%, of carboxyhemoglobin, due to normal enzymatic reactions. Cigarette smokers can have as high as 10%. Rightward arrow: a little exposure to co-rightward arrow. Symptomatic co-poisoning: co-rightward arrow shifts oxygen dissociation curve to left. Rightward arrow inability of HB to unload oxygen at tissue level. Rightward arrow kidney produces EPO. Rightward arrow secondary polycythemia, DX, pulse oximetry cannot differentiate oxy-HB from carboxy-HB. Diagnosis is made on ABGs with cooximetry. Frostbite, freezing of tissue. Rightward arrow disruption of cell membrane, ischemia, vascular thrombosis, and inflammatory changes. Affected tissues typically have stiff or waxy texture. Most affected parts: face, ear, and distal limbs. Revarming should not be done if there is risk of refreezing before definitive care can be provided, as it can worsen tissue damage. Aggressive analgesia should be provided during revarming as it can lead to severe pain. Hot air revarming not recommended. In the field, revarming can be accomplished by holding affected limbs against rescuer's abdomen. CCB not indicated in acute frostbite, used in Raynaud's. Multiple myeloma leads to fatigue, constipation and depression. Hypogammaglobulinemia, bone marrow infiltration by plasma cells, hyperviscosity syndromes are rarely present in these patients. Respiratory, e.g. streptococcal pneumonia, and UTIs are most common infections in labs. Protein gap, difference between total protein and albumin 4G/DL, means upward arrow ed non-albumin proteins in serum. Rightward arrow seen in polyclonal gammopathies, infection, connective tissue diseases, or excess monoclonal proteins. Waldenstrom gammopathy. SPEP, serum protein electrophoresis. Rightward arrow most common screening test for rightward arrow spike, IgG or IgA, identify whether mono or polyclonal proteins. Bone marrow biopsy, more invasive test. Rightward arrow then confirm the diagnosis. 10% clonal plasma cells. Rightward arrow performed only after gathering more information from peripheral blood smears. Rouleau's formation, serum free light chain analysis, SPEP, and urine protein electrophoresis. Bone scans show only osteoblastic activity as in some tumors. Hence not useful for diagnosing rather skeletal survey is more important. Waldenstrom's macroglobulinemia, rare, chronic, plasma cell neoplasm, characterized by abnormal plasma cells which multiply out of control and invade the bone marrow, lymph nodes, and spleen. Typically, there is also production of excessive amounts of LGM antibody in the blood, which causes hyperviscosity, thickening, of the blood. The following are the major signs and symptoms of the disease. 1. Increased size of the spleen, liver, and some lymph nodes. 2. Tiredness, usually due to anemia. 2. Few red blood cells. 3. Tendency to bleed and bruise easily. 4. Night sweats. 5. Headache and dizziness. 6. Various visual problems like retinal vein engorgement due to hyperviscosity. 7. Pain and numbness in the extremities due to a predominantly demyelinating sensoromotor neuropathy. Leukemia's lymphadenopathy, benign LAD, small 1 cm, mobile, rubbery, most often occur in URTIs. Rightward arrow. Observe rightward arrow if grow in size or any symptoms develop. Rightward arrow. Further evaluation common in children and young adults. Malignant LAD, 2.0 cm, firm, immobile. In elderly and smokers. Rightward arrow. Raise suspicion of malignancy and granulomatous disease. Lymphoid neoplasms. Acute lymphoblastic leukemia. PTS with Down syndrome are also at upward arrow risk. Half of patients with ALL may have leukocytes 10,000/L, but 20% have leukocytes 50,000/L, 30 to 50% present with infections, and half with LAD and HSM. Lymphoblasts. Rightward arrow. Lack peroxidase plus VE granules, positive in myeloblasts, but plus VE cytoplasmic aggregates of PA plus VE material. Immunostaining for terminal deoxyribonucleotidyl transferase, TDT, rightward arrow plus VE in 95% cases. Only pre, B and PRET lymphoblasts express TDT. Chronic lymphocytic leukemia. Shows clonality of mature B cells. Hairy cell leukemia, also known as leukemic reticuloendotheliosis B, cell-derived chronic leukemia. Rightward arrow. 20% may have leukocytosis, hairy, projections of lymphocytes. Rightward arrow. Trapped in red pulp of spleen. Rightward arrow. Splenomegaly, bone marrow becomes fibrotic. Rightward arrow. Dry trap, tartrate resistant acid phosphatase, stain plus VE and CD11C marker is relatively specific for HCL, relatively benign course as compared to other leukemias. RX, cladribine, purine analog. 2. Chlorodeoxyadenosine. 2. CDA, toxic to bone marrow. SE. Neurological and kidney damage. Chlorambucil and prednisone for CLL. CHOP regimen for non-Hodgkin lymphoma. Myeloproliferative disorders. Chronic myelogenous leukemia. Late neutrophil precursors. Rightward arrow. Metamyelocytes and bands. Early neutrophil precursors. Rightward arrow. Promyelocytes and myelocytes. CML is usually found on routine blood work in asymptomatic patients but may present with fatigue, weight loss, night sweats or abdominal fullness. Splenomegaly, thrombophilia and anemia are common. Polycythemia vera, PV. But normal oxygen saturation. Bone marrow suppressive medications. Obstructive sleep apnea, chronic hypoxemia. Rightward arrow. Kidneys produce EP. Rightward arrow. Polycythemia. Androgen abuse and hepatotoxicity. Upward arrow. In HCT and HB are dose dependent. Hereditary hemochromatosis. Initial diagnosis based on elevated iron studies and confirmed by genetic analysis of HFE mutation. Serial phlebotomy can significantly downward arrow the risk of cirrhosis and HCC. Superior vena cava syndrome, 60% cases due to lung cancer, ESP, small cell lung CA, and NHL. Other causes, fibrosing mediastinitis, e.g. due to TB or histoplasmosis, or thrombosis due to indwelling central venous devices. When history and PE suggestive. Rightward arrow. Chest X-ray, identify cause in 80% cases. Rightward arrow. Abnormality. Rightward arrow. CT chest and histology to determine type of CA and to guide therapy. Head and neck squamous cell CA, hard, U/L, non, tender LN. Rightward arrow. Always suspicious of cancer and must be evaluated immediately. Rightward arrow. Biopsy LN. Rightward arrow. If squamous cell CA. Rightward arrow. Panendoscopy, esophagoscopy, bronchoscopy and laryngoscopy. Best initial test, to look for primary site. Rightward arrow. Biopsy when primary tumor is detected, gives histologic diagnosis imp in determining proper management and prognosis, H/O smoking and alcohol use. LN enlargement of submandibular or cervical region are highly suspicious of head and neck cancer. Majority cancers in head and neck area are SCC rightward arrow prompt biopsy done to complete evaluation. Treatment of head and neck cancer depends on stage, grade, and histology of tumor. Various treatment options: radical neck dissection, tumor resection, platinum-based chemotherapy, radiotherapy and palliative management. If adenocarcinoma on LN biopsy rightward arrow, consider breast cancer and perform further tests. Prostate cancer, localized prostate cancer rightward arrow radical prostatectomy rightward arrow. In case of recurrence of PSA later rightward arrow salvage radiation therapy can provide long-term disease control for localized recurrent disease. Salvage treatment is defined as form of treatment given when standard treatment has failed to control the disease. Limited disease rightward arrow non-steroidal anti-androgen I.E. Flutamide along with LHRH agonist prolongs survival, but no demonstrable benefits in PTS with orchiectomy. Estromostine, a combination of estrogen limited disease rightward arrow non-steroidal anti-androgen I.E. Flutamide along with LHRH agonist prolongs survival, but no demonstrable benefits in PTS with orchiectomy. Estromostine, a combination of estrogen and nitrogen mustard rightward arrow 40% response rate in castrated men but not well tolerated by men with cardiovascular or hematopoietic disorders. Radiation therapy is the best for management of progressive pain in a patient with prostate cancer and bony metastases after androgen ablation, I.E. Orchiectomy, if METs are localized to a few sites, focal external beam therapy is most appropriate, Q.ID 3847. Spinal cord compression. Epidural spinal cord compression. Suspect epidural spinal cord compression in PT with H/O malignancy, 60% thoracic and 30% lumbosacral involvement, lung, breast, prostate, and most likely tumors, early diagnosis and less neurologic involvement rightward arrow better outcome, although MRI is imp. But for glucocorticoid should not be delayed rightward arrow downward arrow vasogenic edema caused by obstructed epidural venous plexus, help alleviate pain and may restore neurologic function rightward arrow perform MRI rightward arrow ESCC confirmed rightward arrow neurosurgical consultation, radionuclide bone scans and skeletal survey, X-ray of major bones, rightward arrow detect bone mets but not thecal sac compression, hence not recommended tumor lysis syndrome, tumors with high cell turnover like poorly differentiated lymphomas, e.g. Burkitt lymphoma, and leukemias, particularly all and rarely AML, rightward arrow tumor lysis syndrome, metabolic abnormalities associated with TLS, upward arrow phosphate, intracellular electrolyte rightward arrow cell break rightward arrow phosphate comes out downward arrow calcium, released phosphate binds calcium and cause hypocalcemia. Also occur due to release of intracellular products by cell breakdown. Upward arrow potassium, intracellular electrolyte rightward arrow cell lysis rightward arrow K plus upward arrow uric acid, degradation of cellular proteins rightward arrow uric acid. Allopurinol prevent acute urate nephropathy but not tumor lysis syndrome, prompt identification and immediate treatment necessary as may lead to fatal arrhythmias, ARF, and even sudden death cancer-related anorexia/cachexia syndrome, CACS, hypermetabolic state associated with weight loss, anorexia, and excessive reduction in skeletal muscle. Weight loss is multifactorial, due to systemic inflammation and caloric reduction, RX, nutritional counseling and supplementation with enteral or parenteral feeding do a little to reverse CACS. Pharmacologic intervention with progesterone analogs, e.g. migestrol acetate or medroxyprogesterone acetate, or glucocorticoids rightward arrow effective at upward arrowing appetite, causing weight gain and improving well-being. In PTS with longer life expectancy, rightward arrow progesterone analogs better than corticosteroids due to less S/E synthetic cannabinoids are useful in HIV cachexia but not CACS. Pain management in cancer patients. 3 key principles to the use of pain medications in patients with terminal stages of cancer are as follows. 1. Try non-narcotic measures first, unless you are sure, using your clinical judgment, that the patient is in severe pain. 2. Do not be afraid to give narcotic analgesics. 3. Prescribe adequate amounts of medication, initially treat with a dose of short-acting morphine, and then subsequent doses titrated as needed to achieve complete pain control. Once the dose is established, the patient can be switched to long-acting narcotics, and the short-acting morphine is then used as needed for breakthrough pain chemotherapy-induced nausea and vomiting management, in the absence of upward arrow lipase levels, rebound, and guarding on abdominal examination, presence of bowel movement, rightward arrow diagnosis of pancreatitis, perforation and abdominal obstruction are less likely. Dry mucous membranes suggest volume depletion. Rightward arrow 4 fluids are the first line of management. Rightward arrow next treat N/V, serotonin receptor antagonists, e.g. ondansetron, best therapy for chemo-induced N/V target 5-HT3 receptor low S/E profile and highly efficacious acute management and sometimes prophylaxis, sometimes used in combo with corticosteroids. Dopamine receptor antagonists like metoclopramide and prochlorperazine second or third line for refractory vomiting. GI specific opioid antagonists such as methylnaltrexone. Rightward arrow reverse opioid-induced constipation. Anticoagulants and their MOA. Heparin induced thrombocytopenia. Type 1 hit. Type 1 hit is marked by non-immune mediated platelet aggregation. It results in mild thrombocytopenia, platelets rarely 100,000/mm, usually within 2 days of heparin initiation. Type 1 hit does not require intervention and does not cause ill effects. The thrombocytopenia resolves without cessation of heparin. Type 2 hit antibody may manifest earlier in PTS previously exposed to heparin ESP. In those receiving heparin subcutaneously, e.g. enoxaparin, classically occurs at abdominal injection site. Or high-titer immunoassay of blood switch to warfarin once platelet count is 150,000/mm. 3. Thrombocytopenia is mild to moderate, mean naters of 60,000/mm. 3, with minimum risk of bleeding. Severe thrombocytopenia, 20,000/mm. 3, is uncommon. Thrombosis risk is as high as 50% in untreated hit. Venous thrombosis, leg, cardiac, and skin, at the site of heparin injection, is common. Arterial thrombosis, heart, limbs, and CNS, heparin induces conformational change to platelet surface protein, platelet factor 4, PF4, rightward arrow neoantigen formation. Rightward arrow recognition by immune system. Platelet count usually normalizes 2 to 7 days after stopping heparin. Transfusion not needed unless overt bleeding, uncommon in hit. Warfarin-induced skin necrosis, typically occurs within first few days of therapy, usually at large loading doses, ESP. Occurs in PTS with underlying protein C deficiency, involve extremities, trunk, breast, and penis and marginate over period of hours. Left untreated rightward arrow edematous, purpuric, and ultimately necrotic, Rx, discontinue warfarin immediately and administer protein C concentrate. Definitions. Adjuvant therapy. Adjuvant therapy is defined as treatment given in addition to standard therapy. This would be the case if the radiation therapy was given at the same time as the radical prostatectomy. Induction therapy. Induction therapy is an initial dose of treatment to rapidly kill tumor cells and send the patient into remission, 5% tumor burden. A typical example is induction chemotherapy for acute leukemia. Consolidation therapy. Consolidation therapy is typically given after induction therapy. with multi-drug regimens to further reduce tumor burden. An example is multi-drug therapy after induction therapy for acute leukemia. Maintenance therapy is usually given after induction and consolidation therapies, or initial standard therapy, to kill any residual tumor cells and keep the patient in remission. An example is daily antiandrogen therapy for prostate cancer. Neoadjuvant therapy is defined as treatment given before the standard therapy for a particular disease. This would be the case in this patient if the radiation therapy was given before the radical prostatectomy was done. Salvage therapy is defined as treatment for a disease when standard therapy fails, such as radiation therapy for prostate, specific antigen recurrence after radical prostatectomy for prostate cancer. Contents: anemia. 2. Iron deficiency anemia. 2. Anemia of prematurity. 3. Aplastic anemia. 3. Acquired aplastic anemia. 3. Fanconi anemia. 4. Diamond-Blackfan anemia, DBA. 4. Transient erythroblastopenia of childhood, TEC. 4. Neonatal polycythemia. 5. Immunodeficiencies. 6. Wiskott-Aldrich syndrome, WAS. 6. Tumors in children. 7. Wilms tumor, nephroblastoma. 7. Neuroblastoma. 7. Primary brain tumors of childhood. 7. Pilocytic, low-grade, astrocytoma. 8. Pineal gland tumor / pinealoma. 8. Hematology and oncology, pediatrics anemia iron deficiency anemia. = 700 ml/day. Most common nutritional def. In children, an infant's iron stores are affected by mother's iron stores. Prenatal and perinatal hemorrhage. Gestational age of infant at delivery. Recheck in 4 weeks. Rightward arrow if HB. Upward arrow 1G/DL. Rightward arrow. Continue oral iron therapy for 2 to 3 months after HB normalizes to replete. Iron stores. Term infants have sufficient iron stores for 6 months. After 6 months, dietary def becomes the most imp cause of iron def. Often caused by excessive consumption of cow's milk, 24 ounces 700 ml per day. Causes anemia. 2 degrees 2, low iron content of iron in milk. Poor bioavailability of iron from milk. Upward arrow. Intestinal blood loss from cow's milk. Protein induced colitis, children usually asymptomatic. Classic symptoms typically absent. DX usually made on CBC. Peripheral blood smear usually not needed. No further testing in PTS with classic presentation. Anemia of prematurity. RBC transfusion can be given if infant is symptomatic, but it can further exacerbate EPO suppression and delay recovery. Supplemental EPO not effective in preventing need of transfusion. Affects most term infants and severity and onset depends on degree of prematurity. Normal, EPO declines after delivery due to upward arrow O2 concentration in tissues. Rightward arrow downward arrow reticulocyte count. Rightward arrow downward arrow RBC, physiological, rightward arrow occurs at 2 to 3 months in term, preterm, early onset anemia, 40 to 50 days, diagnosis of exclusion, hemolysis, hemoglobinopathies, enzyme defects, and infections should be ruled out. Aplastic anemia. Aplastic anemia can be acquired or congenital. Congenital causes more common in children. Rightward arrow Fanconi anemia is the most common congenital cause. Acquired aplastic anemia, pancytopenia, in contrast aplastic crisis. Rightward arrow downward arrow HB, chemotherapy and chloramphenicol benzene is an industrial chemical, CCl4. Phenylbutazone, insecticides, results from injury to bone marrow by ionizing radiation. Suspect in any child with pancytopenia and any of the recent above things. 5 to 15% PTS with thymic tumors have pure red cell aplasia, but this finding is common in older women and not in children. Fanconi anemia, autosomal recessive or X, linked with clinical findings as below. Other characteristic congenital anomalies such as eye or eyelid changes, microphthalmia, upper limb anomalies, absent thumb, skeletal anomalies, and renal malformations, horseshoe kidneys. May also be present, progressive pancytopenia and macrocytosis. Blood counts start to downward arrow between 4 to 12 years of age, average age of diagnosis 8 years, and initial manifestation is usually thrombocytopenia, followed by neutropenia, then anemia. Most children are diagnosed by age 16 years and have predisposition for cancers, pathogenesis. Numerous genes all believed to be involved in DNA repair have been implicated, DX, chromosomal breaks on genetic analysis along with clinical findings, definitive treatment, hematopoietic stem cell transplantation. Diamond-Blackfan anemia, DBA, also known as congenital pure red cell aplasia, S/S, present in first 3 months of life with pallor and poor feeding. 90% cases diagnosed in first year of life with average within 3 months, suspect DBA when, normocytic or macrocytic anemia, but not megaloblastic as neutrophils etc. are normal, plus reticulocytopenia plus congenital anomalies, present in 50% cases like webbed neck, shield chest, cleft lip, triphalangeal thumb, are present, WBC and platelets are normal, majority cases are sporadic. 15% may have dominant or recessive inheritance. Primary pathology, intrinsic defect of erythroid progenitor cells, rightward arrow upward arrow, apoptosis, programmed cell death, electrophoresis, upward arrow HbF. Normal chromosomal studies, treatment, mainly corticosteroids. Non-responsive PTS, transfusion transient erythroblastopenia of childhood, TEC, acquired pure red cell aplasia, occur in healthy children between 6 months and 5 years. Most cases are diagnosed after first year. No associated congenital anomalies, gradual onset with pallor and downward arrow activity, PE, unremarkable except pallor and tachycardia. Labs, normocytic normochromic anemia, without macrocytosis, HB ranging from 3 to 8 G/DL, and extremely low reticulocyte count. Neonatal polycythemia. Poor placental gas exchange. Exchange in utero hypoxia, common cause rightward arrow excess transfer of placental blood, most common manifestation. This is for symptomatic neonates. Asymptomatic only need hydration by feeding or parenteral fluids. Most neonates are asymptomatic other than appearing ruddy/plethoric, as HCT upward arrow rightward arrow upward arrow viscosity rightward arrow impair blood flow to various organs. Upward arrow RBC mass rightward arrow upward arrow uptake of glucose and calcium by cells rightward arrow hypoglycemia and hypocalcemia. Immunodeficiencies Wiskott-Aldrich syndrome, was. During cell signaling. C/F can range from petechiae or purpura to severe bleeding like intracranial hemorrhage, hematmesis, and hematochezia. Bacterial, viral, and fungal, was gene is found in hematopoietic stem cells. Autoimmune disorders occur in most patients with was eczema being most common, hemolytic anemia, arthritis and vasculitis may also occur, DX, clinical but gene testing allows screening of other family members. Tumors in children. Wilms tumor, nephroblastoma. Affects single kidney. 10% have B/L renal involvement, stage V cancer, usually asymptomatic rightward arrow incidentally found by caretaker or physician. Some may develop abdominal pain, HTN. Hematuria or fever. ESP. If treated early, commonly metastasizes to lungs. Rightward arrow children rarely present with pulmonary symptoms. Management, 1 step, abdominal USG, to differentiate Wilms from other abdominal masses, rightward arrow followed by contrast enhanced CT of abdomen, to evaluate nature and extent of mass, and chest to identify pulmonary Mets. Neuroblastoma, third most common tumor in children after leukemia and brain tumors but most common in first year of life. Arise anywhere in sympathetic chain but most common in adrenal glands, abdominal mass that crosses midline with systemic symptoms. Primary brain tumors of childhood, most common solid tumors in children and second most common tumors in children after leukemias, weakness and sensory changes, cerebellar dysfunction, pilocytic, low-grade, astrocytoma, most common brain tumor in children. SX depend on tumor location but upward arrow ICP irrespective of location as the tumor size upward arrow. Mostly cause SX due to local pressure and do not undergo malignant transformation. Pineal gland tumor / pinealoma, pineal gland located in quadrigeminal cistern rightward arrow produce melatonin. Rare tumors and germ cell tumors account for majority of them. Serious complications result from mass effect. Result from pressure on pretectal region of midbrain near superior colliculus and CN. 3 rightward arrow upward gaze limited and preference for downward gaze rightward arrow known as light, near dissociation. By blocking aqueduct of Sylvius. Anterior mediastinal mass. 2D/D. 2 testicular tumor. 2 seminoma vs non-seminoma. 2 teratoma. Teratoma. 2 hematology and oncology, surgery anterior mediastinal mass D/D, 4 T's teratoma including other germ cell tumors thymoma. Thyroid neoplasm terrible lymphoma testicular tumor. Seminoma vs non-seminoma, serum hormone levels helpful in distinguishing these two, seminoma, serum beta, HCG levels upward arrow in 1/3 PTS and AFP levels essentially normal, non-seminomas, most have upward arrow AFP and a considerable amount have upward arrow beta. HCG may be present in the form of mixed germ cell tumor teratoma, can be distinguished from other germ cell tumors by the presence of fat or calcium, ESP. If in the form of tooth. RH alloimmunization. 2 ABO alloimmunization. 3 hematology and oncology, GYN/OBS RH alloimmunization. Alloimmunization, I.E sensitization e.g. anti-D antibody titer of 1:32, occurs when the mother is Rh negative and has an Rh positive fetus. To prevent the maternal immune system from developing anti-D antibodies, anti-D immune globulin is first administered at 28 weeks gestation and repeated within 72 hours of delivery. A standard dose of 300 g at 28 weeks gestation can usually prevent alloimmunization as the risk of alloimmunization is very low before this time. If PT develops placental abruption, undergo amniocentesis, chorionic villus sampling, and external cephalic version earlier in pregnancy, then KB test should be done to determine dose of anti-D immune globulin. 50% of Rh negative women will need a higher dose after delivery, placental abruption, or procedures. The Klehoer, Betka, KB, test is commonly used to determine the dose. Leaving ghost cells ABO alloimmunization, O plus mother and father of plus rightward arrow less severe hemolytic disease of newborn as compared to Rh incompatibility as varying titers of IgG antibodies are formed and IgM antibodies are also formed. Titers can be high in certain populations like Africans and African Americans leading to severe disease, otherwise less severe disease, may be asymptomatic or with mild anemia or jaundice in newborn, can be usually treated with phototherapy alone, only IgG can cross placenta contents dysphagia. 5 Oropharyngeal dysphagia. 5 Esophageal motility disorders. 6 Achalasia and pseudoachalasia. 6 Achalasia. 6 pseudoachalasia. 6 diffuse esophageal spasm. 7 dyspepsia. 7 causes. 7 management. 8 GERD. 8 evaluation and treatment. 8 complications. 8 globus sensation, hystericus. 9 pill esophagitis. 9 esophageal rupture. 10 secondary to endoscopy. 10 characteristics of gastroesophageal mural injury. 11 esophageal carcinoma. 12 upper GI bleeding. 12 recommendations/threshold for packed RBC transfusion. 13 recommendations for infusion of fresh frozen plasma. 13 recommendations for platelet transfusion. Transfusion. 13 recommendations for whole blood transfusion. 13 acute erosive gastritis. 13 gastric carcinoma. 14 gastric adenocarcinoma. 14 mucosa-associated lymphoid tissue lymphoma, MALT lymphoma. 14 gastric outlet obstruction. 14 malabsorption syndromes. 15 causes of steatorrhea. 15 celiac disease. 16D, xylose absorption test. 16 pancreatic insufficiency. 17 tropical sprue. 17 lactose intolerance. 17 small intestinal bacterial overgrowth. 18 zinc deficiency. Deficiency. 18 selenium deficiency. 19 collagenous colitis. 19 irritable bowel syndrome. 19 inflammatory bowel disease. 19 ulcerative colitis. 20 toxic megacolon. 21 minimal bright red blood per rectum, BRBPR. 22 factitious diarrhea. 22 diverticula of GI tract. 22 diverticulosis. 22 acute diverticulitis. 23 uncomplicated. 23 complicated. 23 Zenker diverticulum. 24 colovesical fistula. 24 mesenteric ischemia. 25 acute mesenteric ischemia. 25 chronic mesenteric ischemia. 26 ischemic colitis. Colitis. 26 retroperitoneal hematoma. 27 angiodysplasia. 27 colonic polyps. 27 classification of polyps. 27 1. Hyperplastic polyps. 27 2. Hamartomatous polyps. 27 3. Adenoma. 27 Lynch syndrome. 28 colorectal cancer. 28 screening. 28 methods of screening. 29 cirrhosis. 29 common causes of cirrhosis. 30 clinical features of cirrhosis. Cirrhosis. 31 ascites. 32 causes. 32 evaluation. 32 ascites fluid characteristics. 33 treatment of ascites. Ascites. 33 hepatic hydrothorax. 33 esophageal varices. 34 prophylaxis. 34 treatment of variceal bleeding. 34 hepatorenal syndrome. 35 acute liver failure. 36 ischemic hepatopathy. 37 drug-induced hepatitis. 37 alcoholic hepatitis. 38 non-alcoholic fatty liver disease. 39 hepatic encephalopathy. 40 management of hepatic encephalopathy. 41 spontaneous bacterial peritonitis. 42 solid liver masses. 42 hepatic angiosarcoma. 43 bilirubin metabolism. 43 hyperbilirubinemia in adults. 44 hereditary hyperbilirubinemia. 44 Gilbert syndrome. Syndrome. 44 Crigler-Najjar syndrome. 44 Dubin-Johnson syndrome. 45 Roeder syndrome. 45 Wilson disease. 45 biliary tract diseases. 46 evaluation of elevated alkaline phosphatase. 46 primary biliary cholangitis/cirrhosis. 46 vanishing bile duct syndrome. 46 primary sclerosing cholangitis. 47 cholelithiasis. Cholelithiasis. 47 risk factors. 47 gallbladder stasis. 47 small bowel, ileal resection, or ileal Crohn disease. 48 estrogen-induced gallstone formation. 48 management of gallstones. Gallstones. 49 gallstone ileus. 49 biliary colic. 49 acute cholecystitis. 49 post-cholecystectomy syndrome. 50. Acalculous cholecystitis. 50 emphysema II cholecystitis. 51 acute cholangitis. 52 cholangiocarcinoma. 52 acute pancreatitis. 53 acute pancreatitis 2 degrees to atherombolism. 53 treatment of uncorrectable causes of acute pancreatitis. 54 drug-induced acute pancreatitis. 54 chronic pancreatitis. 55 severe pancreatitis. 56 complications of pancreatitis. 56 pancreatic pseudocyst. 56 pancreatic cancer. 57 cancer of pancreatic head. 58 cancer of pancreatic tail and body. 58 malignant biliary obstruction. 59 pharmacology.